so that we can start on time, as we have two plenary sessions at parallel, one here and the other one for the antimicrobial resistance in the auditorium. So request at least all those volunteers who are there to ensure that they come back to amphitheater or the auditorium as we move ahead. Thank you.
Hello. Hello.
For the sessions, we have two plenaries going on parallel. One is here at NCD and the other is antimicrobial resistance in the auditorium. And we'll be starting shortly. Thank you.
A very good morning, respected dignitaries, esteemed members, delegates, and guests. I hope you all had a very restful evening and are ready for another engaging day at the annual conference of the Indian Association of Preventive and Social Medicine Gujarat chapter. It is an absolute honor to welcome you back for the second day of this significant event. Yesterday, we had the privilege of participating in engaging discussions, thought-provoking presentations, and valuable networking. Today, we are excited to continue our journey with more sessions designed to expand our understanding of key public health challenges. But before I proceed any further, on a somber note, I would like to place a humble request for a 2-minute silence for our colleague, Devang Patel, who has unfortunately lost his father in the early morning hours today. He has been instrumental in organizing this conference, and we would like to observe a 2-minute silence for the same. Thank you so much. Good morning again. I am Dr. Smita, consultant and medical supervisor here at IIPHG, and will be guiding you through today's sessions and activities which promise to offer more than just opportunities for collaboration and innovation. We are committed to fostering an environment where we can work together to improve health outcomes across the nation. Today we have Dr. Vihang Mazumdar, a PSM stalwart, who has joined us today, and we would like to felicitate him. I would request Dr. Anish Sinha to kindly do the honors. Thank you so much, sir. And thank you all for your presence, and I look forward to a day full of inspiring and meaningful exchanges. Let's make the most of this gathering as we continue into our first plenary for today, which is the pediatric non-communicable diseases, which is growing a public health concern encompassing chronic conditions such as diabetes, asthma, obesity, cardiovascular diseases, and certain cancers that affect children and adolescents. While NDCs have traditionally been associated with adults, their prevalence amongst children is steadily increasing, often due to factors like poor diet, physical inactivity, genetic predisposition, and environmental influences. Early onset of these conditions can lead to long-term health complications, making prevention, early detection, and effective management very crucial. Understanding the unique challenges and the strategies for addressing these pediatric NCDs, it is essential to improving the health and well-being of future generations. I would now like to invite on stage our chairs for this session, Dr. Narayan Kaunkar, Health Specialist, UNICEF, Gujarat State, and Dr. Komal Shah, Associate Professor and Lead, NCDRC at the IAPHG. Dr. Narayan Kaunkar is a health specialist with the UNICEF Gujarat, having almost 2 decades of experience in leading and managing health programs that aim to improve the lives and well-beings of mothers, children, and adolescents. He has earned certificates in dynamic leadership, health program management, and core commitments for children and humanitarian action. He has also contributed to the COVID-19 response, coordinating critical public supplies, monitoring the situation, and supporting the staff safety. He has published several papers and good practice documents and received multiple awards for his work in the community. Dr. Komal Shah. Dr. Komal Shah is an associate professor and the lead of the NCDRC at the IIPHG, Gandhinagar. She has also more than 108 publications, 2,475 citations, and an H index of 26, and an I index of I-10 index of 57. Her research interests are evidence synthesis, metabolic disease management, risk stratification model, cohort studies, community-based intervention for NCD prevention. Her research collaborations are the London School of Hygiene and Tropical Medicine, University of Melbourne, Campbell South Asia, the Foreign Commonwealth and Development Officer, Karolinska University, Sweden, UNICEF Gujarat, DBT, DST, WHO India, ICMR, and DHR. She is an academic editor of various journals. I would now request the chairs to kindly take over the proceedings and introduce our speakers for today.
Thank you, Dr. Smriti, for this wonderful welcome. And I take this opportunity to briefly orient everybody for this particular plenary. And it's a unique kind of a combination where we have speakers sharing their experiences related to pediatric NCD, what are their field experiences, clinical experiences, and what they seek as an advocacy or a policy piece which should be absorbed. We see very active participation from all of our delegates who are sitting over there, be it student or medical professional or researcher, public health professional. There is something really special for you. So I want all of you to be part of these interactions, and this is not a very conventional kind of speaker-led program. Here we want a lot of insights from you so that at the end of this session we got both the parties talking to each other, open a dialogue related to this particular area, and then come up with something which is palatable to both the parties. So I would humbly request you to participate with whatever activity we have placed. Before that, I'll just briefly share some of the insights related to our NCD work. So I would request our IT team to share the presentation. So we have established a center, global center for non-communicable disease-related advocacy and research. I'm really happy to share that we have multiple national, international, and regional partners ranging from LSSTM to Karolinska Institute to University of Melbourne, and state people on board. We have Dr. Chakshu over here today, who is a state WHO consultant. We have Professor Narayan over here, who is like leading UNICEF Gujarat. We have clinicians, Dr. Kamal Sharma, Dr. Nikhil, Dr. Jalak, and we have program people, Dr. Radha with us. So the ultimate aim of this particular center was to actually prepare a consortium of like-minded people who are working in all the domain of NCD, how we can strengthen the program to the clinical practice, to the guideline. And yesterday, our President PHFI said such a wonderful statement that whenever you are designing something, you need to remember that our national bird is peacock, not ostrich. So we need something which is for us, by us, developed by us, for our people. And I think that's what is the agenda of this particular meeting today. These are a couple of programs. We have more than 80,000 participants cohort, which we are following up for non-communicable diseases. They are from various states, ranging from Gujarat to Northeast and now to the Central India. Apart from that, we are actively into evidence synthesis, which is very much relevant in our practices. So right now we are following up, which is a global guideline. But with this center, we try to develop something through evidence synthesis, which is applicable for our own setting. And very recently, this pediatric NCD advocacy has started, and I'm really glad that we have collaborated with UNICEF and all our partners for pediatric NCD. So, of course, we are sitting on that epidemic. We are seeing every third or fourth kid in the urban setting getting affected by obesity, higher screen time, but we were not talking about it. So this particular plenary is planned to just sensitize all of us for that and how we can take it to a greater level of advocacy. On the World Heart Day, we had our first annual conclave of this global center, and that's where we oath to undertake this particular initiative. So around 3 lakh children from various settings, various schools, public and the private school, will be enrolled in our cohorts, and they'll be enrolled from 1,000 schools. Their age will be ranging from 5th to 9th grade, and we will be doing multiple activities with them. So they will be ranging from health promotional activities, screening them for their NCD-related risk factors, and empowering them to take charge of their health and their future adulthood health is our motive. And yes, this is some of the glimpse from our recent first annual conclave meeting. I'll end the things over here, but then I'll start with some of the fun activity which are placed for our delegates. So there is one very known kind of famous personalities whose pictures I'll be displaying over here. Because this plenary talks about pediatric diseases, I would like you to guess their name, which is very, very easy task to do, but you need to identify their struggle also. Whomsoever raises the hand first, I think they'll be getting some perks for that. So all up, please be vigilant. What is the first slide telling you about? You don't need to speak it loudly, otherwise somebody will take up your prize. Okay, Nick Jonas, correct answer. What is his fight? So maybe we can go to Seva Rural, sir. He's clapping for you, sir. We should all clap for him. So maybe I'll ask Dr. Rupali to hand over the prize. Next one. So sir is there. Maybe Nidhi, you would like to give him this mic. There is another lady also who was also struggling with this.
Arjun Kapoor.
You have to say a second name also, sir.
Sonam Kapoor.
Very nice, yes. Kapoor siblings, yes. And their disease or their fight?
Obesity, probably.
Excellent, yes, sir. So maybe I'll seek help from our research partners to hand over the little perk of, who is this? Yesterday when I was preparing this presentation, some of the guys in my group said that they will not take even a fraction of second to say his name. But I'm not sure about his fights. But I'm not getting the name also. Dr. Abhishek, I think people are not aware about it. Yes, and his fight? You need to say both the things, otherwise I don't think we'll be. You got the? That is not allowed. That's a clear-cut cheating. Okay. So, okay, we don't have answers, so we'll be giving it, it should be shared between ma'am and sir. So his fight is this. He had congenital heart defect, so which is a bicuspid aortic valve defect. Last, one of all of us favorite, Messi. Yes, and the disease. Gulecha sir, top 2% scientists are absolutely not allowed it. Okay, so this is something nobody can answer. Oh, sorry, our panel members, you are also not allowed it to answer that. So, yeah, I gave the answer because nobody was able to answer that. So, congenital growth hormone deficiency. So, this shows us that situation is actually messy. And we want all of our experts to untangle this entire aspect for us. We are privileged to welcome all of them. And I would humbly request them all to address the epidemiological, clinical, policy, advocacy, all the pieces of this puzzle so that we can come to a, not a conclusion, but we can have a better understanding of these problems. So with this, I would formally inaugurate and start the session with our first speaker, who is actually backbone of this entire initiative, Dr. Narayan Gaonkar, and I would request him to briefly set the context and tell us why this is much more needed in our setting. So I welcome you. So before that, let us first welcome all of our speakers on the dais. So we have interventional cardiologist, Professor Kamal Sharma with us. So we welcome him on the dais. Then we have Dr. Nikhil Modi with us, so I welcome him. We have Dr. Jhalak Upadhyay, endocrinologist with us. I welcome ma'am. We have Dr. Radha from WDF with us, and I would welcome her also. So over to you, Dr. Narayan.
Good morning, everyone. How is the Josh? You are all very quiet. Okay. Thanks to Komal and IAPAG and IAPSM for giving us a wonderful opportunity, the morning session today, dedicated to the pediatric NCDs. I really thank Komal and IAPAG for bringing all the people whom you see as a heterogeneous group, but we are working for the common cause. So let me quickly go through a background to this entire topic. And many of you are aware, NCDs in children and adolescents now actually becoming a very serious concern for all of us, also in UNICEF. So this is invisible. We don't see them as much of NCD you see in adults. So you may not even know what is the magnitude of the issue. But those who are in the field working for long understand how much is the load of these NCDs in children and what is that we can do. I also really appreciate Komal for bringing an angle of, there is an issue, the disease, people are affected, but we need to create a world which is free from stigma and discrimination. And we have engagement with some celebrities, including some queens and some kings who are not currently ruling, but they are in the country, and they don't mind sharing their experience, including the Queen of Udaipur. We had engagement with her last month. So what I mean to say is, let's understand the issue, let's help people live their life normally without going through any hardship or any discrimination. So I seek all of your support to take this journey without any stigma and discrimination. That's my first request. So we would like to see a world where every child born in the world survive and thrive and transform to his best or her best potential. So, but if you look at the programmatic priorities and epidemiological trends, there are some challenges which the world is facing. There is a shifting epidemiological trends. The burden of NCDs is increasing, and 74% of all deaths globally are due to NCDs as per the Global Burden of Disease report. And 77% of total NCD deaths are in LMICs, low middle income countries, where we also belong to. You see the stars, this is actually profile of countries. And if you see the second one, 5 to 19 years, actually major share of disease burden or deaths in children is actually due to NCDs. So 71% of the preventable adult deaths from NCDs are linked to risk factors that start in childhood or the early adolescent period, which gives us an opportunity for all the public health people gathered here. It gives us an opportunity to advocate. We have our General Secretary, who is also author of a book on NCDs. I had a chance to have a look at the book yesterday. The President of IAPSM yesterday committed to work more on prevention of obesity and NCDs, and also make efforts to kind of keep euglycemia in diabetic patients. I really appreciate, sir, your leadership, but it's very important for us to understand 71% of preventable things, at early childhood. So then cardiovascular diseases are leading cause of death. We'll hear more from our experts today. And but the good news is many early life course interventions have an ability to prevent NCDs later for millions of people in the world. So if it's available, why don't we try them? Why don't we do it? Okay, looking at India, many of you are aware, I also have experts in the panel who know India's situation much better. But deaths due to NCDs are rapidly increasing. And our colleagues who teach epidemiology, if you see the India's population pyramid, it was tapering. Now it is bulging in the center. It's bulging here in the center. But our epidemiology, if you see the age pyramid, India is a very young country. It's continued to be a young country for a few more years. But when we become Viksit Bharat, 2047, we try to start age fast. So this will bring a lot of the aged population who will have a lot of NCDs. The burden will increase. So we need to have our protocols and systems in place to deal with them. So most common NCDs in children include asthma, diabetes, cancer, cardiovascular diseases, and obesity. This you know. And approximately 20% of children in urban area and 10% in rural area are affected by NCDs. So do we have a supporting system to care for them, if they already develop NCD? The International Diabetes Federation estimates there are 128,000 children and adolescents with type 1 diabetes alone in India. So I was just discussing with my colleagues yesterday, and I tried to figure out, what will be the load in a district, average district of, say, 10 lakh population. We will have around 160 children with type 1 diabetes. This is estimate. So if we have them, do we know them who they are? And some of them are known to our clinical pediatricians, but not known to many of our public health people who are talking about supply chain, drug logistics, follow-up. Many of us do not know these faces. We need to know them as a public health care providers. So 3.1% adolescents use tobacco, 1.3 use alcohol, children, not adults. And the mean age of initiation of tobacco is 14.2 years, and alcohol is 13.4 years. Do you agree, or is it a surprise for you? It's happening, please accept it. Don't challenge us on this, we can provide detailed data, but please accept and start understanding the issue happening in and around our families and our children, and try to work on them. 25.2% of adolescents did not meet the WHO recommended level of physical activity. I like IAPG students dancing, singing. It's good for the health. It helps NCD prevention. So please continue. I was also talking, we actually want to promote physical activity and sports in the schools and in the societies. Many societies do not have a place to play for children, So now, there is some shockers which was actually difficult for me to internalize. There is a national comprehensive national nutrition survey. I will give you a glimpse of Gujarat data just for your consumption. The age group, the red one says 10 to 19, and the blue one says 5 to 9 years. The triglyceride level, you see, 27.6% children have high triglyceride level. I have a definition for all of them, can be shared. It is actually, you Google a comprehensive national nutrition survey, you will get the pictures for all the states, okay? And you see the low LDL, which is at 25% in 10 to 19 years. And pediatric diabetic, it's hard to believe for me. I don't know the sample size, other thing, but it says 20. And diabetic, pre-diabetic is 20, and diabetic is 2.9%. That doesn't, this means there are a lot of epidemiological shifts had already happened. What kind of food our children are eating? what kind of activity they are into, increasingly more of gadgets and less of physical activity. So these processes we can already see changing, which is a threat. We need to reverse these trends. Okay, but we also are blessed with a lot of opportunities. Thanks to our Prime Minister leading a sickle cell disease entire movement in India. We also have a universal healthcare coverage under Ayushman Bharat, which has got two approaches. There's a PMJ scheme for treating these people. At the same time, we have health and wellness centers. Entire country, we have a sub-center, primary health centers converted into health and wellness center. In urban area, we created new physical infrastructure of health and wellness center, big opportunities. So physical infrastructures are being created. There is a good political will, but what is really happening on the ground, what more need to be done, needs a reflection. I have colleagues from WHO and people who work with WHO. There is Ayushman Ka Amrit Mahotsav. There is a commitment from Government of India for treating, screening and putting 75 million of people affected by diabetes on treatment. Chaksu is here. Chaksu can share some experience later what's happening in Gujarat. So these commitments are good for the country. Okay, and if you see the first one, the prevention and control of common non-communicable diseases guideline, it exists for the adults, but in a few weeks' time, we are actually working with Government of India, WHO, UNICEF, and all the partners, and the professional bodies represented here. So we will be coming up with something great soon for rolling out pediatric NCD guidelines in the country. So I request today, when I was discussing my panel members, to my mind, we need to have a twin-track strategy, which we use in many diseases, including disability. First, those who already know, where we have a cohort, let's do something and treat them, help them. The second one, entire population, let's educate entire population for how to prevent NCDs. There are very simple things. You have learned, all of you, in your public health. So these are some of the prevention methods, eating healthy, weight control, physical activity, there are lists available. So let's follow prevention as a major strategy, but also those cohort where we already know the status, let's do something to keep them in good control. So at national level, UNICEF also committed to work in 8 states to start with, and at national level to get data sets to enhance the capacity of the care providers, do some policy advocacy with the states. India is a big country with every state, health is a state subject. So we need to advocate at state level to leverage the political will and resources. We will be working with the communities and also the groups, lived experience sharing, lived experience sharing by people, and encouraging others not to feel discriminated, not to feel stigma. So we have to work with the caregivers to enhance their capacity. And this health is too big for the health sector alone. So we need to work with other sectors. I will not go in detail looking at the time, but we'll discuss more. There are marker conditions for pediatric NCDs. We also listed in the second bullet, if you see, there are a lot of national schemes existing already. In terms of the program, they are there. We have a health and wellness center, RBSK program, school health program. We have a RKSK program for adolescents. We have a national program for climate change. So multiple programs are available. 1 second only. So we need to have a team working with the multiple department. We need a collaborative efforts. NCD ARC is good for us. So my last speech is actually a call for inclusion of children at the heart of NCD agenda during the 4th high-level meeting of United Nations General Assembly. It's happening on September, this coming September. So all the partners are working together. If that gets done, we will probably make a very strong pitch to work on pediatric NCD across the world. So I look at all the partners and the panelists to support this thing and also take it forward. So my request, to all of you, let us work early. So if we change the beginning of the story, we can change the whole story. So please join hands in making this transformation for the country. Thank you so much.
Thank you, Dr. Narayan, for setting the stage and actually emphasizing why we need to have this advocacy. To take it forward, I am really humbled and happy to welcome Professor Kamal Sharma over here on board. Can we have his introductory slides? Because though he doesn't need an introduction, I know a couple of them, like 22 gold medal holder and interventional cardiologist with a vast background of dealing with lot of surgery, complicated cases, Over here, you can see that 188 publications awarded as a best excellent teacher. He has also cracked civil services, but he's chose to be cardiologist. So we are really happy to have him on board today. And we welcome you, sir. So with this, we'll hear from him regarding the cardiological aspects of pediatric NCD. Thank you.
Good morning, everyone. Thank you, IIPHG, Dr. Narayan, Dr. Komal, Dr. Deepak for inviting me. Yeah, so a lot of you guys must be wondering what is an interventional cardiologist doing in this meeting in public health. If we go to the basics of public health, intervention doesn't mean opening a coronary artery. Intervention means primary intervention as well. And I think it's time that we as a society need to wake up that curing a disease once it has set in and preventing its complication is not the primary treatment goal that a therapy or as a science we all, or as a public health individual, we need to focus on. What we need to focus on is to prevent those diseases happening, picking them up early, and intervening before the complications set in. And that's what I'm going to touch upon about heart disease in children. When usually you talk about heart disease in children, people think about two disorders. One is congenital, another is rheumatic. But what we are missing out, and as before I submitted this slide 7 days back to Dr. Komal for being uploaded for the presentation, in those 7 days we got through one paper of our own recently published looking at young MIs less than 30 years of age. More than 150 patients that we published in the post-COVID era, risk profiles were equally worse as compared to the other cohorts of the patients who were older than 30. And then I was discussing today, pre-meet discussion with Dr. Narayan and our team, that we have programs designed for people who are less than 18 or 12, and we have programs designed for those who are above 30. What happens to people in between is anybody's game. There are no programs to roll over children into adulthood. That's where the missing link lies. So basically, when I talk about today, I'm going to take you through, of course, focusing primarily on congenital heart disease, rheumatic heart disease. We'll also talk about antenatal nutrition strategies. I'm glad NCDR and Dr. Komal are working on some of these aspects as well. Early diagnosis and intervention, and of course, screening and preventive strategies of RHD. So when I was asked to propose what I intend to submit, I had proposed 8 topics, but then I was told that will be too much to talk in 8 minutes or 10 minutes. So I chose in order of prevalence, in the AI tool, what is the strategy that should be adopted as the primary and most important to focuses, and it comes out to these two, and I believe the other things are going to be covered by my other colleagues who will touch upon how prevalent diabetes in children is. Just to keep it interactive, let me have hands raised for a simple question before I move on to hit on these 2 questions. The first pathological development of atherosclerosis or deposits of cholesterol in arteries is called as fatty streaks, histologically speaking. Anybody can guess at what age does this start even in so-called healthy individuals? How many of you think it is 3rd decade? Please raise your hand. How many of you think it is earlier than that? Please raise your hand. How many of you think it is in 1st decade? It is actually 1st decade. Children as young as 5 years, 8 years, when you do an MR and look in their aorta, fatty streaks deposits start, and that's the stage when the atherosclerosis is yet setting in. That's the time when you need to intervene, and as the lifestyle disorders we are talking about become worse, more of the sedentary fighting out rather than fighting amongst themselves between the kids. They fight on the PUBG or whatever games they play rather than physically fight with their siblings is actually adding to their sedentary lifestyle, apart from the dietary interventions that the parents don't want to cook on the weekend, and so the food is ordered on Zomato. Of course, those apps earn more money. The food is not something that what you're consuming is probably the most healthiest. So the top 3 cardiac disorders in children, apart from rheumatic heart, if you look, it's the congenital heart, in that order, the ventricular septal defect and the tetralogy of Fowler. If you look at the congenital heart, we have robust programs, especially in our Gujarat, I can talk about, that we have school health program which screens all school-going children, and that have brought down substantially the diagnostic gap that existed in picking up congenital heart disorders. And how often it is present? 8 to 10 per 1,000 live births. That we are talking about nearly one child out of 100 is having a congenital heart disease, and I'm not even talking about rheumatic heart, or I'm not even talking about atherosclerotic development disorder. VSDs of these constitute 30 to 35%. Now, you know what is the problem with VSD? If you don't operate a large VSD before 6 months of age, these children become inoperable. They get Eason-Mangarized, which means their PA pressures are so high that you operate, they die. And that's why they live for the rest of their lives with a disorder which is neither curable but also a burden socially, emotionally, financially on the family as well as the society. That's why picking it up at birth becomes very crucial. Tetralogy is a cyanotic heart disease. This is what Rashtriya Bal Swasthya Karyakram also looked into, and this is the data which was published across nationally, where the IMS BHU involved 34,000 plus individuals, noted again 19, which is like 2 out of 100 with congenital heart, of which 1/3 were VSD, 1/5 were ASD, and 1/6 were tetralogy. If you combine these, you have practically covered majority of simple congenital disorders that need to be addressed in the first year of life. And that's why it's not school-going children that you need to intervene. That intervention has to come from the clinician. When the pediatrician auscultates a child that is born, that's when the first diagnosis of these disorder needs to take place. That's why the preventive strategy has to involve clinicians, pediatricians at the time of birth. We all know about folic acid supplementation. This has become pretty strong and robust in our intervention strategies. Everybody gets it. It's a very important aspect. 20 to 30% CHDs come down. But very important, Dr. Komal had published a paper about vitamin D. It was looking into COVID. But there is also studies that have showed about vitamin D supplementation in prevention of congenital heart disease. So also zinc, and there are also some other vitamin. The evidence synthesis for these studies is something that we need to generate for our part of the world. Systemic reviews have shown some evidence linking maternal micronutrients to fetal CHDs. Folic acid is pretty much known, but what is very much still needs to be evaluated in our subgroup of population is maternal supplementation, not just of folic acid, but also some other multivitamins, including micronutrients like zinc, B12, vitamin A, copper, selenium, ferritin, etc. Other problem is over-the-counter pill. If you have headache, you and I would probably treat ourselves being a doctor. If we are not, very likely in the rural area, the patient goes to an over-the-counter pharmacist and he asks, I have headache, and he'll get a prescription, maybe a paracetamol, maybe a more stronger one, maybe some other drug. The over-the-counter preparation has been linked. This is one thing that if we can block without prescription, if the maternal prescription of drugs can be avoided, a lot of disorders can still be prevented. And the list is long. It's not just anti-epileptics. The valparates and the phenytoins and the carbamazepines and lithiums are of course known. But even simple drugs like ibuprofen, over-the-counter preparation, which is associated with disorders like transposition of great arteries, or even indomethacin, or even for that matter, simple-looking viral infection, which is actually a rubella infection, because maternal assessment, for that perspective, mother has not thought of getting it assessed. Maybe something that's, again, urinary tract infection, nitrofurantoin has come back in a big way. It also leads to congenital heart disease. Vitamin A access, on the other hand, is another disorder which leads to outflow disorders. So at least no over-the-counter prescription is one strategy that can look at. And that's the cardiac continuum that we are talking about. Recognize them early, diagnose them early, refer them early, stabilize, treat, and follow up quickly. Rheumatic heart disease is equally preponderant, though we say now the new fevers don't happen, but still 1 out of 100 children get it. In the global context, we still harbor 40% of world rheumatic disorders. It accounts for a large amount of population which goes into the adulthood with a disorder, and then the later on tertiary interventions take place. How do we pick them? You cannot do a throat swab to practically everyone, but you can surely find out that who are at risk. 470,000 new cases of acute rheumatic fever are being diagnosed annually in countries like India, which still is a big number. We think that we have killed this, but there is no program like malaria eradication, like tuberculosis eradication in our part of the world to look at and address disorders like rheumatic heart disease. Malaria gets you fever once. Tuberculosis gets one therapy and you can probably cure it. But once you get rheumatic fever, it stays with you forever. That's why it's a prevalence disorder, not an incidence disorder. You need to stick to finding out these cases early, go aggressive, look at the comprehensive data sets, look at the healthcare access, find out who are the patients, who are the one who are at risk. There are dermatoglyphics pattern, there are HLA linkages with this, there are throat swab studies. We know that only max 3% of streptococcal infections will translate to rheumatic fever. In a pandemic, 0.3% in an endemic situation. But identifying those 1% of individuals who are at risk is equally important. This is a paper called Rheumatic Study published from AIIMS, India, which showed still 1 out of 1,000 children school going had echocardiographic diagnosis. So what's probably missing out is more echocardiographic diagnostics rather than throat swab. And there are data we can dig out. Girls are more likely, between 11 to 15, more likely in government school setups. Look at kacha houses they are staying at. If they have more than 4 people living in the community, if the BMI is on the lower side, these are the subgroup of the patient that probably can go a mass screening in terms of picking up for rheumatic. And what you can do is do a throat culture, rapid antigen, or nucleic acid amplification. But those are difficult strategies to do. For the sake of time, I'll be quickly finishing it. The clinical implementation can include targeted population, community health initiative, follow-up and treatment with the available resources available and cost-effectively utilizing rapid bedside test, which a paramedic can also do. Need not a cardiologist do a throat swab analysis to identify with rapid test rather than cultures, which have a lot of problematic area. A rapid diagnostic test, which has a 89.7% sensitivity with 98.4% of specificity, can easily, quickly pick up a child who is developing acute post-streptococcal rheumatic fever tendency. A group A beta hemolytic streptococcal throat swab can be a good screening methodology. That's where we can use, with its implication being that once you can pick it up, you can actually kill the acute rheumatic episode from translating into rheumatic heart disease early. So echocardiography and combining throat swab is the two strategies which its advantages and disadvantages. I can share this presentation, whosoever is interested. For the sake of time, I'll conclude that both throat swab and echocardiography are important in rheumatic heart disease. Early diagnosis, you need to follow them up, as I said, in a linear cohort. Pick the children up and follow them up into adulthood rather than trying to map down specific subgroups of individuals. And before I end, I want to emphasize this, that young CADs are pretty common. Every now and then you will be seeing patients, young children getting heart attacks, sudden death in children. That's another perspective, but I've limited myself only to these topics because they wanted me to specify about topics which are more prevalent. And when I searched the AI tools, the two disorders in terms of the proportionate of numbers that emerged most important were congenital and rheumatic. So I've limited myself to that. I'm open to discussion and collaboration beyond the meeting. Thank you very much.
Thank you very much for presenting the cardiac aspect of this entire thing and moving from the clinical aspects to the public health policy, or what could be the need where we can bridge the gap between both the things. So with this, we will move towards another aspect of this pediatric NCD where Dr. Radha, I would be inviting Dr. Radha, who is from World Diabetic Foundation, who is program manager over there, to talk about a little bit related to advocacy and how we can bring all of these things in the sides of the policymakers and the program people, where we need a better level of advocacy for pediatric. Can we have an introductory slide? Yeah. So she is MD in community medicine and public health expert. She was heading a lot of NCD departments of a variety of states. She has worked in Goa. She was leading the flagship program of that STEMI. Cancer registry also, she was a university rank holder. And I think now she is leading this World Diabetic Foundation program. We are indeed very happy to have her on stage, and we look forward to learning how do we go ahead with the advocacy of this kind of diseases. So I welcome you.
Yes, at the outset, let me thank Dr. Komal, Dr. Narayan, and the organizers of this conference for giving me an opportunity to speak here. So I will be speaking about advocacy and how we can advance diabetes-related advocacy work with focus on children. Sir has already spoken about the burden of diabetes. So diabetes, as we all know, is not only responsible for disease burden and premature mortality, it also impacts quality of life, causes catastrophic expenditures to families, is responsible for high health system costs, and also affects economic productivity of individuals. A little bit about my organization, which is World Diabetes Foundation. It is a Denmark-based philanthropic foundation, which is essentially a funder of diabetes-related initiatives in low and middle-income countries. Our focus is vulnerable populations and humans, those that are in greatest need. So WDF's approach to diabetes is a three-pronged approach. We focus on care, which is a bulk of our project. So by care, I mean screen, diagnose, treat, prevent complications. Then we have an emerging approach, which is the primary prevention approach, about which I'll speak in greater detail. And of course, both these are anchored through strong advocacy. World Diabetes Foundation works through its partner networks in different countries. A glimpse about what we are doing in India. WDF has been present in India for over 22 years, but you might not have heard so much about it because we've been silent players in the field. India has had more than 100 projects in different states, including Gujarat, as you can see in the map, which have been funded by World Diabetes Foundation. Across 22 states, we have till now supported partners with more than 25 million euros. So that has been the scale. We have had a tremendous variety also in the projects that we have had. Some of our noteworthy partnerships, ongoing partnerships in India include our partnership with World Health Organization, which is essentially technical and operational support to the NPNCD program. We have two projects in the state of Madhya Pradesh being implemented by Japaigo and Maternity Foundation. Both focus on gestational diabetes. And we have an upcoming partnership with Piramal Foundation, Madras Diabetes Research Foundation, and Public Health Foundation of India, which looks at prevention of NCDs in tribal population of 5 states of India. So these are our ongoing partnerships. So in terms of type 1 diabetes, although right now we do not have a type 1 diabetes related project that we are funding in India, these are some of our ongoing initiatives across the world. So we have a multi-country project which looks at integrating type 1 diabetes care into the health systems in Eastern Africa and Middle East. Then we have a beautiful program for type 1 diabetes children in Pakistan. It's called Meethi Zindagi. We have one project which looks at integrating type 1 diabetes in the NCD care system in Western Uganda, another one in Sudan, a few more in African countries. We have one in Mali, in Togo, and 2 projects in Malawi. Now, while I will not be talking about each of these in detail, if you go on the website of World Diabetes Foundation, you can read in much detail about each of these projects. What is the size of funding? What are the interventions? What are the outcomes? What are the learnings? And I think I am here to facilitate cross-learning, because something that we might be starting afresh in India, in a certain state of India, has already been tried and tested and implemented somewhere. I think we should exchange learnings and see which best practices from which projects can be adopted in our local cultural settings. In terms of advocacy, which is the theme for this session, I would like to highlight here that the right way to advocate for NCDs is to not advocate for NCDs alone. Here we look at intersections of NCDs between maternal and child care, NCDs in infectious diseases like TB and HIV, and also NCDs in humanitarian settings, which is basically people who are displaced because of natural calamities, refugees, war victims, and so on. WDF's country partnerships inform their global agenda and vice versa. So we support demand-driven projects. So if any of you have good ideas which require funding, you can apply. It happens through open call. You can just check the website and all the details are there. So now going a little bit into the technicalities. So I am going to focus on type 1 diabetes. So when we speak of advocacy, there are number of things. There are like infinite number of things that you can advocate for. I have bucketized this, starting with policy gaps. So the first thing to advocate for when it comes to type 1 diabetes is your state recognizing type 1 diabetes as a public health problem? Why or why not? And how can this be changed to align with the growing public health demand? I think it is the responsibility of public health experts like you and me to show governments that kind of evidence that this is a problem and this needs to be acted upon urgently. Secondly, has the state established cross-sectoral linkages? Let's say, for example, the health department and the education department. Why education department? Because we're talking about children, we're talking about schools. So are the two departments talking to one another, and how can we facilitate this? And here is a point I think I would like to emphasize, I couldn't emphasize more on this. There is a huge network of people living with type 1 diabetes in India. There are peer groups, there are support networks, and these are people with lived experience. They deserve a seat on the policy table. They deserve to be a part of the decision making when you design a program. Involve people with lived experience because they will tell you exactly what needs to be done, where and how. In terms of health service delivery gaps, the first step is issuing clear guidelines on who is to be tested, how and when. I'm sure most of us know we do not have clear-cut guidelines for type 1 diabetes, and most children are actually diagnosed when they land up in the hospital with a hyperglycemic or hypoglycemic complication. So we actually don't need to wait till the child is in hospital and have clear-cut guidelines on who is to be tested and how. All the healthcare providers need to be sensitized on how type 1 diabetes is to be managed, be it at primary, secondary, and tertiary level. These can be also included, like type 1 diabetes related training can be included in the standard NCD module that is there under the NP NCD program. We need to address the human resource gaps, which means we need more endocrinologists, primary physicians, nurses, diabetes educators, and counselors who are available and equipped to handle this scenario. Supply chain is an important part of this to make insulins available up to the primary health care level. And it's not just insulins, but also the right type of insulins in this situation. Wherever you feel the syringe and vial may not work, we have to advocate for insulin pens, pumps and CGMs on case-to-case basis in special circumstances. In a lot of villages of India, people do not have refrigerator. So where would they store an insulin vial? So I have seen in my experience people keeping insulin vial in a clay pot just to keep it cool. So there are cold packs which are available which can store insulin for a prolonged period of time. These also have to be advocated for along with insulin. Yet another challenge here is a single unit, like an insulin unit which has 1 unit dosing. 1 unit is too much for a child, and they tend to go in hypoglycemia. They need 0.5 units to be injected, but we do not have 0.5 unit syringes available here in India. This is something we promote the marketing and manufacture of 0.5 unit syringes through indigenous production. Self-care kits to be given to children and adolescents. A lot of our type 1 diabetes programs have this. So they'll have like a teddy bear which has markings on its abdomen of where to inject insulin. There will be material which is focused on boosting confidence and morale of children, and so on. And like Sir said, we need proper workshops which can help children transition from pediatric to adult care in terms of how to face the world, how to transition, how to change, from your pediatrician to maybe a general physician or an endocrinologist, and the psychosocial support involved in that. Data registry is a basic need. The current estimate of type 1 diabetes index is that we have close to 9.5 lakh children living with type 1 diabetes. But is this a real figure? No, it's just an estimate. As of now, we do not have definite count of how many children or young people are there with type 1 diabetes in India, which is why having a data registry is a basic need. And we also need advanced epidemiological research behind the onset and clinical manifestations of type 1 diabetes. At school level, it is not just the teachers, but also the school administration, students, and parents who need to be sensitized on type 1 diabetes with educational resources and SOPs. For example, how would you handle a type 1 diabetes kid during an exam? Or if there is a hypoglycemic emergency in school, if the child is being bullied, do you have a no discrimination policy for type 1 DM in schools? And of course, possibilities of integration with the Rashtriya Bal Swasthya Karyakram as well as the district mental health program. A little bit about the felt needs of patients. We need helplines, counseling centers, legal support for patients. We need type 1 diabetes champions to be featured, forecasted, not just Bollywood and sports stars, but our local champions who have made it big in life despite having type 1. And we need to also align global and local priorities through advocacy, which Dr. Narayan has already touched upon. Who can advocate for pediatric NCDs? I will just take maybe a couple of extra minutes. Healthcare providers at all levels, sharing clinical experiences, patients and their family by strongly demanding for the highest quality of care. Academic and research institutions like IIPHG and medical colleges by generating evidence through research. Development partners like WDF, WHO, and many others by providing the necessary technical support and funding. Now, when it comes to government officials, demand for every politician to have childhood NCDs in their political manifesto. If you are an opposition, encourage them to question the running government on what is being done for childhood NCDs. If it is civil society organizations, alliances, associations, federations, pharma companies often feared and you feel they have commercial interest. But mind you, in NCDs, we have such a strong private sector which is pushing you to have NCDs through commercial determinants of health. Please take help of insulin companies, medical device companies, health tech companies in countering that push and pull. And media, please engage media to ask the right questions and disseminate the right kind of knowledge. I think this forum already knows about life course approach, but I will quickly touch upon it. Fetal origins of adult disease already established. That's the famous Barker's hypothesis. We have the thrifty gene hypothesis also, which postulates how people in today's times develop diabetes because of an overload of glucose that we put in our body. Early onset of behavioral risk factors, commercial determinants of health, and triple burden of nutrition. So conventionally, it was only overweight and obesity which was linked with diabetes. Today, we have enough nutrition to know that, enough evidence to know that undernutrition, overnutrition, and micronutrient deficiency, all three are linked with diabetes. And we have novel risk factors emerging like air pollution. This is the famous picture from the paper on life course approach. I will skip this for now. So what is the impact of this on advocacy? So when we know that diabetes is something which starts, at the fetal stage in the health of the mother, baby, feeding, infant and young child nutrition, everything is responsible for the individual developing diabetes in later life. This opens up opportunities for us to also strengthen our maternal health programs and advocate for NCDs through the life course approach. Multi-sectoral prevention is essential here. So what we mean by this is advocate through FSSAI. We have the Eat Right India program. Advocate through midday meal programs, education department, sports department. We have the Fit India, Khelo India initiatives. Leverage them. Town planning department, demand for open spaces to walk, for gyms, open gyms, and legal measures like KOTPA. So I feel it is also important to measure long-term impact through life course approach when it comes to NCDs. So it's important for that. For that, we need horizontal integration across programs, risk scoring, biomarkers. We need to learn to measure behavior change, address long-term impact through predictive analysis, and learn to measure environmental factor. For example, how obesogenic is a given environment. So we need to also move away from the conventional metrics little bit. Summary and key takeaways, I will flash on the screen. Type 1 diabetes is A growing problem. Advocacy is the need of the hour. A combination of approaches is required, and life course approach is the way forward for advocacy through multiple channels and multiple sources. Thank you so much.
Yeah, thank you, Dr. Radha, for this. I think the umbrella is so wide and it actually encompasses a lot of diseases. It's very difficult to encompass everything, but we are having a panel discussion after this. So their audience question and our panel members' questions will be very well taken up. So we would request speakers to take care of the time as well. So our next speaker is Dr. Jhalak Upadhyay, who is a pediatric adolescent endocrinologist, and she's from Rajkot, but she has completed her MD in pediatrics with gold medal, and she is executive committee member of ISPE and honorable secretary of pediatric government of Gujarat wing, also joint secretary of IMA Rajkot, and she wears many hats. And but the best thing is, I think not only she is advocating for this, she is practicing, generating a lot of awareness about how do we reduce these risk factors in kids. So over to you, Dr. Jhalak, and we look forward to a fantastic presentation on some of the most common pediatric risk factors.
Thank you so much. Good morning, everyone. At the outset, I would like to thank IIPHG, IAPSM, and UNICEF to give me this opportunity to talk on pediatric obesity. We know it's deadly pandemic actually. This is what happened initially. 1980, our screens were bigger, we were thinner. And look at this now. 2010, 20, screens are getting smaller and we are getting obese, fat. So what this lady says is, if more than 50% of population is obese, I am not overweight, I am average. And this is what is happening. We need to revise our growth chart every 10 years. This is secular trend. The nutrition is getting better, but this is what happens. So if they are 50% is obese, she says I am overweight. So India is facing double burden of malnutrition. We are still struggling with undernutrition and now the other extreme, overnutrition. So childhood obesity, right now, we are at the figure of 14.4 million. That is what we know. And it is predicted by 2025, it will be 17 million obese children in India. And it all obviously weighs down our economy. We have direct costs, which refers to the total healthcare expenditures resulting from treating overweight and obesity-related diseases, and indirect costs represent the economic value of lost time, productive capacity, or quality of life due to overweight and obesity. So India ranks second in highest number of obese children in the world. And it was almost 22 and now almost up to 35 to 40% of children are obese. And what does it lead to? A lot of things. Poor self-esteem, depression, eating disorders, sleep apnea, liver disease, gallstones, musculoskeletal like osteoarthritis, but even type 2 diabetes. We know that India is diabetes capital of the world. And we have highest number of cases of diabetes in the world. And as Sir talked, even cardiovascular diseases, coronary artery disease in younger age. So this is a new age epidemic and mostly over last decade, and we have seen a lot after COVID. Obesity has almost tripled, but now it's labeled as chronic disease. Obesity has to be labeled as a chronic disease. Lifestyle plays a major role. Diet is primarily to blame. And why? We receive mixed messages, and we know social media, Instagram is flooded with so many messages, what to eat, how much to eat. We faced with mouth-watering advertisements alongside campaigns promoting daily physical activity and proper nutrition, but many opt for fast, cheap, and filling options. Even mothers these days, they don't want to cook. And it's easy to give them a packet, and children are happy, and you don't have to force them to eat what they want. So often leads to a diet rich in fat, calories, and sodium. We know the butter, salt, sugar, they are really bad, which is low in nutrients and vitamins. So this is what we use for children, BMI charts. Can you tell me what is the BMI cutoff for overweight and obesity in us, like in adults? So 25 and 30 for others. For we Indians, because we are more prone to develop diabetes and other metabolic complications, for us it is 23 and 27. for overweight and obesity respectively. For children, we have to plot it. It's not 23, 27, it's according to the growth charts. So this is how we plot and look at it. But some people tell me, हमारे घर में सब obese है, लेकिन किसी को कोई problem नहीं है. That is why I keep this on my desktop and we show them this is metabolically healthy and unhealthy. These are two terms, metabolically healthy obesity, unhealthy obesity. Even if they are metabolically healthy, that means they don't have diabetes, they are non-motensive, normal lipid profile, everything, low inflammation activity, but that doesn't mean they are not at cardiovascular health risk. With obesity, it is 58%, overweight 34%, greater risk of cardiovascular disease. So obesity in children these days is mostly due to exogenous. I won't be covering other aspects, but prevention is the key for a healthy future. Our children are our future and they need to be healthy. So to tackle obesity, whenever a child comes with obesity, we tell them 70% is your diet, only 30% is your exercise. So role of diet and food is very important. So efforts for nutrition education, food choices and public awareness is very helpful. Government should ban the advertisements of all the packaged foods. Increasing physical activity is crucial, as ma'am already covered life course approach. I won't be talking much on it. But promoting exercise in school, which has to be compulsory because child spends a lot of time in school during when the child is awake. So that is important. Promotion of active transportation, parks, playgrounds, it is important. So this is what I show them. In short, it is 5-2-1-0 approach. 5 portions of fruits and vegetables in a day, colorful fruits and vegetables, eat seasonal, eat local, be a role model for your own child. You should practice it, only then the children will follow. No fruit juices, have fruits instead of juices. 2, cut down the screen time. The research shows that the screen was introduced in child so that the child can eat. During weaning is the most common period when the screen was introduced, but child should eat without screen. 1 hour of physical activity and 0, no sugar or soda drinks, no fruit drinks. Promote water as the best fluid. So 5-2-1-0, practice this approach for everyone. It applies to us even. This is balanced meal. How does our plate look? 50% of fruit and vegetables, which most of us don't follow. 1/4 carbohydrate, 1/4 protein. So it should be a balanced, healthy meal. Junks. This guideline has been published by Indian Academy of Pediatrics, readily available on internet. It's about junk food, ultra-processed food, nutritionally inappropriate food, caffeinated, colored, carbonated beverages, and sugar-sweetened beverages. And this was put up in in the newspaper. And what does it say about the fruit juices that promote water as the drink, and fruit instead of fruit juices, no caffeinated drinks, and how much for the age group 5-9 and 10-18 has been mentioned. This is freely available on internet, Junks guidelines. It should be freshly cooked home food, but remember, that doesn't mean that home food is healthy. You also have to look at the oil consumption of the family. Reading food labels, this has to be taught to each and every child after 10 years of age. What are they consuming? What are the preservatives, sugar, salt, sodium content? Balancing is very important. Less than 2 hours of TV, mobile, video games, sitting. Sitting is new smoking, we know that. So do not sit for more than 30 to 45 minutes at a stretch. Maximize physical activity, 1 hour per day. Adequate sleep. Sleep hygiene is important for children. Meals, as we discussed, family time and hobbies. That should be maximized and this should be minimized. After obesity, I would also like to touch upon neonatal screening for congenital hypothyroidism. This topic is very close to my heart. Wherever I go, I spread a word on this. And this has to be my take-home message today. Thyroid is a gland which is situated in our neck. It's a butterfly-shaped gland, and it produces hormone called thyroxine. This has become very common, thyroid disorders. Maybe some or the other of your family member may be suffering from some thyroid disorder. So in children, thyroxine is essential for normal growth and development, both physical and mental. It's the most common hormonal disorder in children. This is a wide spectrum. It could be a newborn or an adolescent. If it's newborn, it can be congenital hypothyroidism. If adolescent, it is acquired or autoimmune hypothyroidism. So this is HPG axis. I won't go into detail of this. What are the usual symptoms and when do we have to screen it? So when we talk about symptoms, newborns have minimal or no symptoms at birth. Only 10 to 15% of hypothyroid newborns present with diagnostic clinical features. So 10% in the first month and later on 35% in the first 3 months. And that is why, because they have minimal or no symptoms, that is why it is very important to screen them. It is the birthright of every child to undergo thyroid screening because it is the preventable cause of mental retardation. Just 1 rupee for 1 tablet and the child does wonderful in life. Otherwise, this child will be mentally retarded for life. So the red flags, what are the red flags? How does a child present with congenital hypothyroidism? And when they present, it's very late. That is why screening is must. I won't go into details of the red flags. This is for a pediatrician. So why do you think it is important and should it be made universal? Whenever we look at the screening tool, which conditions are to be, to have screening? So because we know that congenital hypothyroidism is quite common, it can be detected very easily, efficiently. It can be detected at a stage when they would not be ordinarily clinically detected because symptoms appear later, can be treated effectively, and it's very cheap, causes morbidity if untreated. Because it's very common, 1 in 1,000 to 1,200. It's very cheap, doing TSH 150 to 200 rupees. Clinically, we know that only 10 to 15% present during first month, otherwise they are asymptomatic at birth. We know it's very effective and very cheap. And delay in starting treatment. Beyond 14 days, if a child with congenital hypothyroidism has not been screened, child will suffer with mental retardation. The IQ will fall by 5 points every month if you delay the treatment. So congenital hypothyroidism is an ideal condition for screening, and remember, treatment needs to be started as early as before 2 weeks of life to avoid the sequelae. So usually how do we screen? Just maybe one more minute. We can take cord blood at birth, because when I talk to my colleagues, pediatrician colleagues, they say that parents say, my child cannot have hypothyroidism, my child is fit, why do I prick my child and why do I pay for the test? So what I tell them, you can do a cord blood TSH. After delivery, take blood from cord so you don't have to prick the child, send it, and it can be done. So this is very effective, just 150 to 200 rupees for screening of TSH. If it is more than 20, we recall the patient, do the other workup and start treatment giving thyroxine before 2 weeks of age to prevent mental retardation. So these are the guidelines freely available on our website, ISPE, Indian Society of Pediatric and Adolescent Endocrinology. So if we start treatment before 3 months of age, IQ will be 89, between 3 to 6 months, 70, after 6 months, 54. So once we start delaying the treatment, if the child doesn't get treatment, this is what the IQ, this is what happens with the IQ of the child. So that is why I say, because it is asymptomatic at birth and it is preventable cause of mental retardation, which is very cheap, just 1 rupee per day for the treatment. It is the birthright of every newborn to undergo thyroid screening. Kerala is the state which does universal thyroid screening of each and every newborn since 2012. And this will be my request to the government that it has to be implemented in India, in private and public sector. I advise and request all of you, કોઈ પણ બાળકને રમાડવા જાઓ, ઝબલું આપવા જાઓ, તમારા કુટુંબમાં હોય તો પૂછવાનું થાઇરોઇડ ટેસ્ટ થયો છે કે નહીં. That's very important. So diagnosis delayed if made by clinical. And these are all the sequelae with the child face if they are not treated. Growth retardation, speech defects, poor attention span, and behavioral issues. So to summarize, please diagnose it. Universal screening is must and treatment to be started before 2 weeks of age. Thank you so much.
Thank you, Dr. Jhalak. I think we'll get back to you. We'll come back to you for this Kerala model and how we can work upon this hypothyroidism very effectively. How do we see it integrated in the public programs? But quickly, in the interest of time, let us move to our next speaker, who is Dr. Nikhil Modi, very renowned neurosurgeon, head of the Department of Neurosurgery at GCRI, who has done multiple different kind of a complex surgery, and he'll be taking us through the cancers related to pediatric population. We look forward to your presentation. Thank you.
Thank you very much, IIPG and Dr. Komal. It's an uncommon and but very pleasant experience of presentation and sharing the podium under the sunlight. On a brighter side, we can say that induces a lot of brightness and adrenaline, and lighter side, we can say that decreases the incidence of drowsiness in delegates. So, anyways, Dr. Narayan elaborated one important topic, that he said to get the successful outcome, basically your strategy has to be divided into till the zone of output 5. Now, our job as a panelist is to provide the strength and the data and to health information at the ground level. So our job falls into the output part 1. And if we can see the early, we can change the story. So for those at our tertiary center, Gujarat Cancer Research Institute, we registered the data of primary brain tumor, not in pediatric age group, but the overall incidence of CNS tumor, primary brain tumors, metastases were excluded of last 21 years. And the GCRA is being drained by surrounding all 4 major states. So this was the incidence. And out of those, we could detect that these are the incidence of more than 10,000 brain tumors in all age groups. Now talking about pediatric age group. So pediatric age group, that's first and second decade, that is 7 patients out of 10,000 patients. So that's 7%. So probably 10 patients who are exposed to the tertiary center with the brain tumor. So out of those 10, minimum 1 patient is pediatric brain tumor. That's something significant, because overall the incidence of pediatric brain tumor is less, but because it's a tertiary center, hence the drainage is maximum. So it should not give the wrong information. Now these are one more surprisingly data. As per the MD Anderson and Sloan Kettering data, the pediatric malignancy, the cellular supracellular incidences are more common, which comes at the 3rd spot. The cellular supracellular, it's a craniopharyngioma, which carries significant morbidity, although it's a benign tumor, but the behavior makes it more malignant. But unfortunately, the location of CP angle and frontal lobe location comes on the top in our study. Why? I'll tell you later on. Something about pediatric brain tumor, it's something 1 to 2 per 1 lakh. It induces high morbidity and mortality. It's the second most malignancy after leukemia. Males are more affected than females. The causes being, I'm talking about most malignant tumors, not the benign one. The causes being change in the DNA cells and early genetic mutations during in utero condition. High income countries have better survival rate, whereas low income countries have hardly 1/3 of pediatric cancer gets proper treatment. Forget about survival. It's a proper treatment, optimum cure. These are some of the most common pediatric brain tumor. Now number 3, pilocytic astrocytoma. If provided proper optimal care, then the complete surgical excision, the output is excellent. It is at most benign tumor and it does not carry significant morbidity or mortality. But let me focus significantly on the number 2 embryonal tumors, that's a medulloblastoma. In a nutshell, medulloblastoma is the death call. And till date, even the developed countries or science does not have a concrete, definite answer for medulloblastoma. It happens in the posterior fossa. And unfortunately, the child presents to us, till its head acquires the size of the coconut. So that's a late presentation. And the second most unfortunate presentation about medulloblastoma is the occurrence is most common in first 3 or 4 years, where if you offer the surgery to the pediatric age group, per-operatively, even the blood loss of 50 ml and 100 ml, child can succumb per-operatively. Majority of them are very vascular. So the pediatric age group they are not able to tolerate the heavy blood loss during the surgery. Second most problem, they cannot tolerate the chemotherapeutic agent, which is optimum part of the optimum treatment. Third most, radiotherapy is compulsory. Now, as per the literature, we cannot offer the pediatric age group if he is less than 3 years old. So it's a dreaded tumor. And out of 10 pediatric brain tumor, medulloblastoma carries the 2 to 3 patients. So it's a significant cause of morbidity and mortality. Even in the MD Anderson, 80 to 90% pediatric age group with medulloblastoma, the lifespan is 36 months with the optimum treatment. Now syndromic presentation. Now go back to my slide number 3. Why the incidence of CP angle cerebellopontine angle tumor and the posterior fossa tumor carries the significant incidence in our study? Because at our tertiary center, the syndromic presentation is relatively more common. Why syndromic presentation is more common? It's not the increase in the incidence, but probably they happen in the low socioeconomic status, and there is lack of education provision to their parents, and that is where we can urge, that is where regarding the policy making. Like MD Anderson has induced the policies where if the child comes to a syndromic presentation like neurofibromatosis type 1, type 2, or tuberous sclerosis, they have made it mandatory to offer the screening test for all family members. Likewise, I can see the Gorlin syndrome, Turcot syndrome, and Leigh-Fromini syndrome. Leigh-Fromini syndrome is the malignancy which affects all family members. And they could provide the early detection in case of Leigh-Fromini syndrome, and the policy have been implemented way years back. Now, another example is Japanese population. Japanese population, they are significant. They have set the hallmark in case of brain aneurysm. Now, brain aneurysm is lethal problem overall, not in pediatric age group, overall, and AV malformation. Even in United States, 80% of the patients with aneurysm, they die on the spot. Rest of the 20%, if they reach to the hospital, out of 20%, hardly 10% survive, and rest of the 10%, they remain disabled throughout the lifetime. So what did they do? They initiated the screening procedure by means of digital subscription angiography. Can we imagine that? Invasive procedure as a part of screening and diagnostic tool. And they have been curing by means of flow diode or stent-assisted coiling. So it's a part of the successful policy. Apart from pediatric brain tumor, these are some uncommon pathologies. Now, this is positive aspect of our country. I will highlight those positive aspects. Neural tube defects. Scoliosis, myelocele, lipomeningocele, spina bifida occulta, dermal sinus, low-lying cord. Now, incidence is less as per the live birth in United States, and still developing countries still high. Way back 10 to 15 years, we used to operate as much as a tertiary center, we used to operate as much as 25 to 30 minimum cases per year of lipocele, lipomyelocele, lipomeningocele. And the reason was, most common reason was lack of folic acid deficiency, lack of folic acid supplementation during the antenatal visit. And now, we are hardly operating 2 or 3 cases in a year. So that's a positive aspect, and that's the result of, recently I was going through the literature, and I found out that a lot of schemes are going on, PM, SMA, Pradhan Mantri Swasth Matrutva Abhiyan. I'm not the best person to comment on that in front of all genius from the PSM department. But they have made it compulsory to provide the vitamin B12 and folic acid supplementation even in the antenatal visit. And the results are, we have been getting the results. Now the surgeries have become rare. Now what are the problems related to these spinal problems? You know, imagine yourself carrying with your kids throughout the life with a foot drop and bladder bowel incontinence. So that makes the life very horrible and miserable. And some of the majority of neural tube defects, post-operative results are not so encouraging. So we saw that early, and for the last decades, yes, we have been getting good results. So those are the part of the policy: better nutrition for women, folic acid supplementation, even at the peripheral level, improved antenatal care, high resolution ultrasound, and biochemical markers availability, which was not there previously a decade back. Some of the uncommon tumors, round cell tumors in pediatric age group, they carry significant mortality. Now, other hemoglobinopathies, these are part of non-communicable disease in pediatric age group. If we get the patient of brain hemorrhage with the hemophilia, can you imagine the availability of cryoprecipitation factor rate availability? At how many tertiary centers it is readily available? Very few, very few. And it is one of the most common factor of mortality. Thalassemia major, sickle cell anemia, we have been getting patients with increased incidence of hepatitis B virus and hepatitis C virus because of the repeated blood transfusion. So it's a wrong transfusion policy, which we need to work out at the ground peripheral level. As I said, anticipation is better than important, is important way of looking forward. Imagination encircles the world. If we can find out the genetic, by means of genetic screening, we can work out on the medulloblastoma patients, because that's ultimately death call. And even if you detect in a late stage, then that is a death call. Carry-on message should be genetic screening of family members. Quality medical education. Quality tools, high resolution ultrasound to detect congenital anomalies at the ground level. Transcranial Doppler to detect hydrocephalus. Now, transcranial Doppler is a simple tool, it's a good, non-invasive tool. It's not a rocket science to detect only the significant amount of fluid, which can be carried out without any paramedics at the peripheral level. It is not available. So basic idea is provision of good infrastructure, and good team. Those are two important success of pillar. Thank you.
Thank you very much, Dr. Nikhil, for actually bringing such a different perspective and a different topic for the discussion, especially for public health people. Now, with the interest of time, we will have one question to be discussed and to be given to our panel members. And I would request our audience to come up with two important questions that they felt that need to be discussed, and we'll be taking up after this panel's discussion. So my first question will be to Dr. Kamal. Because lot of programs at a pediatric level, they are being run by government and they are providing fantastic services. But they are till the age of 18, and our adult program, they starts from the age of 30. So how do you see, or what would be your recommendation to strengthen this transition of care? What could be done to seal the gap between that 18 to 30 years of the population? So your insights on that.
I think with the adoption of integrated data management that is going to come with the healthcare, every child as soon as he is born is being monitored digitally for the health record is going to be going in a long way. So I think there are two ways to look into this. Either you try to come back and try to identify gap between 18 to 30 and try to look at the whole cohort, which is going to be much more difficult to do. Easier is identify high-risk group, which you already have with the RKBAS and other schemes, school health programs. You've already identified those children and follow them up prospectively as a cohort. So already known high-risk individuals and follow them up prospectively is a better way of doing the things. Other is identifying at-risk cohort between those for the time being between 18 to 30. And I just gave an example of rheumatic heart. Like if you want to pick up preventive strategically, acute rheumatic fever, we know we cannot do a mass screening of all school-going children with throat swab because the incidence is going to be 0.3%. It's not a good strategy. Good strategy is identifying people who are at risk and at higher risk. For example, as I showed, children of government school between 11 to 15 years, predominantly girls who live in a kacha house, have more than 4 occupants in a house, who have BMI less than 20. If you add all this up, the risk profiling of these individuals, then the likelihood of picking a throat swab becomes 20 times higher. So that's easier way of taking out, because endemically the prevalence is going to be just 0.3% of a throat swab. You do a mass throat swab assessment, it's just waste of human and all the resources that you have. So 2 ways to do it: identify already diagnosed disordered children, follow them up prospectively, fill a gap till 30. Secondly, identify high-risk cohorts, both in children and between 18 to 30, and bridge the gap to provide a continuum of healthcare.
Thank you. So as far as I could understand, you are focusing on risk prioritization of the already existing data pool that we have. So that could be one of the very important strategy. The same question I would like to float to Dr. Nikhil also, because you have also been dealing with the patients which are majorly being covered by all of this program. So what are your thoughts on that? How do we make sure that after the age of 18 also, these people are getting their treatment till the age of 30?
Yes, ma'am. And the answer of your query goes back to the detection of the early syndromic presentation. Because the pediatric age group, imagine a kid who is blind and who is deaf and is bedridden. So the syndromic presentation carries the maximum burden, and the parents accept that it is hard luck and unfortunate part of their life. But till date, there is no policy of genetic screening and detection, even in the patients who have been affected at the age of 10 years with the significant posterior fossa tumor or bilateral CP angle tumors. So as much we can stop, we can stop the further occurrence of the disease in case of, like government introduced the policy in case of thalassemia major. Thalassemia minor, couple should not get married, hence the incidence could go down. Whereas still it is part of tuberous sclerosis and Stooges-Weber syndrome, where patients are moving and mobile, but they come up with a child affected with those syndromic presentation. So work has not been done in those aspects yet. Okay. So that's the most important and significant aspect of.
Okay. Thank you. So I think these clinical learnings and the learnings from the field are very much needed for us to look into the program, how we can strengthen this. Quickly moving to Dr. Radha regarding the psychological factors that might influence, because all of these are chronic and this is going to stay with the child for relatively longer duration of time. So how the psychological factors can be taken care of in these families and the child itself?
Yes, so I'll speak with a focus on type 1 diabetes. I'm sure we all would agree. The number one problem here is stigma. For a lot of families, especially when it's a girl child with type 1 diabetes, the problem is not how are we going to manage the disease. The problem is shadi kaise hogi. So I feel it is stigma, which is the number one problem that is affected, which needs to be addressed. Number two, I feel for a lot of children and young adults who are taking insulin, there are schools, colleges, or maybe workplaces, if they are young adults, do not have the kind of privacy or that kind of setting where they can peacefully inject insulin. You have to maybe lift your shirt up or inject, lift your pant up. So they don't have that kind of privacy. We know how toilets in schools are and toilets in government facilities are. Thirdly, I feel for a lot of young people, it is burnout. Imagine having to track your blood sugars all the time. You have to monitor what you are eating. You have to calculate. You have to, think. You have to be constantly aware that I have to take insulin. You have to prick yourself multiple times a day. And when this takes up so much mental space, it also causes fatigue and burnout. I think in addition to this, there is also a lot of discrimination. Young people being bullied, or when they are young adults and they are applying for jobs, there's a whole lot of discrimination there. So these are some of the psychosocial factors. This is also a point where the support groups can actually come in. The patient support groups, let's say you have a network of many individuals, young individuals with type 1 diabetes, a network of parents whose children are also having type 1 diabetes, and a lot of such beautiful support groups and platforms already exist in India. So if you do know a child with type 1 diabetes, they can be linked to a support group. So how the support groups help here is, firstly, the child feels that I am not alone. A lot of children feel, why me? What did I do to earn this? When they meet other children who are also having the same problem, that gives them a sense of psychological support and comfort. Secondly, these are communities which come forward to celebrate your wins. Let's say somebody with type 1 diabetes runs a marathon, or somebody comes first in their school, or you win a prize at an elocution competition. You have an entire community of type 1 diabetes individuals who's supporting it, celebrating it with you. For parents who have children with type 1 diabetes, I think caregiving is also a cause of psychological distress and burnout, and they feel responsible for their child all the time. They feel guilty. So having other parents to talk to is also something that a support group can offer.
So absolutely, maybe the support group, peer support group, when they see people like them, I think that's a pillar of strength. So thank you very much, Dr. Radha. And the last question, I would address it to Dr. Jalak. The first one, you were talking about the universal health coverage for congenital hypothyroidism. And as far as our knowledge goes, Kerala has already adopted it. So very quick reflection, maybe 2 take-home points from that. What were the best practices they adopted, which can be an insight for Gujarat as well?
So requesting government that so what happens is THS screening is done after 48 hours of life, not before that. And if we have early discharge policies, like normal delivery, they get discharged earlier. So what happens is we can request to do cord blood TSH. There may be some more false positive reports, but we can recall them and confirm with venous blood. In 2012, I think Gujarat government started this program of universal screening for newborn, which had around 7 disorders. So ideally, after a child's birth, it should be screening for 7 disorders. One of them is congenital hypothyroidism, and it is a preventable cause of mental retardation. So I stress more upon that, and doesn't cost much. So if it is early discharge, we can make this policy of doing cord blood TSH for after delivery, like immediately the child is delivered, take cord blood, send it for TSH. Some of the government hospitals do not do TSH every day in their laboratory. They do only once a week. So that has to be done every day. For private sectors, I believe we should, there should be this awareness amongst gynecologists and pediatricians for doing TSH for of each and every child. Otherwise, a very simple policy is everybody will go for birth certificate लेने के लिए. वहाँ पे अगर TSH नहीं है report तो देना ही नहीं है birth certificate. And the other thing is marriage certificate. Thalassemia का report नहीं है couple का तो marriage certificate भी नहीं देना है. This has to be very much clear for them.
Fantastic. What a practical application she has shared. We'll come back to Dr. Narayan for giving us the overall insights, like how we should do the advocacy. But before that, maybe we can have 2 questions from the audience, if it is there. I'd go back to Dr. Chakshu, who is a WHO state representative. And I have specific questions, maybe related to, yeah, maybe Dr. Narayan, you would like to state that questions, and we can take it up.
Yeah, Chakshu is actually working for a couple of years now in Gujarat, basically this hypertension control initiative. So we had a meeting with WHO. So we were trying to learn from India Hypertensive Initiative, which can help for pediatric NCD, because in the hypertension initiative, major audience were actually adults. So from the learning you have, the advocacy has reached Prime Minister's office, and India is committed to put 75 million people on treatment. So guide us on what is the learning from Gujarat which can help us to sharpen our focus on pediatric NCDs.
Thank you. Thank you for inviting me. Thank you IIPHG, thank you UNICEF, IAPSM. So coming to that learning from IHCI. IHCI has been India Hypertension Control Initiative, which is initially rolled out in 5 states since 2018 and gradually expanded to across country. In Gujarat, it has been there for more than 3 years. So in that, what we adopted is a model for managing hypertension, diabetes at primary healthcare level. A standard treatment protocol where a MBBS medical officer can diagnose and treat patient, and the evidence is that almost 90% of patients with primary hypertension can get their BP under control with this model. In that, we also strengthen the supply chain of drugs. NCD, we all know, majority, there are certain lacunas in availability of the drugs, and that too adequate availability. So we also strengthen that adequate availability part and follow-up. These are chronic diseases. So like it is not we can do 1 or 2 or 3 months visit, lifelong follow-up. So follow-up has been ensured at sub-center level by community health officer, which has been posted since like around 2017 or 18. So with that, in that line also, I can just brief about something on type 1 diabetes in Gujarat state, which we have already been advocating through WHO also for pediatric age group. In that, currently a model has been under a pipeline where a package of supplies, including insulin, their monitoring kit with glucometer, glucose strip, also looking at a certain younger, like toddler age group, junior pen, also under consideration. They are monitoring with urine ketones at home level. So all these things are also under pipeline, almost certain stages in level of procurement. So that is also, we are promoting that this, or at least supply can be ensured at the primary care level, so that the patient will get regular treatment, they will not default on their treatment, so that their adequate level of control of blood sugar at present for type 1 diabetes can be achieved. So that is what the model we are working for pediatric NCD, and can be explored further for other NCDs in pediatric age group. Thank you.
Thank you, Dr. Chakshu. So,
Audience, any questions? The panel will be happy to answer. Maybe 1 or 2 quick questions. Yeah, we can see the hand there. Can you please pass the mic over there? Please keep the questions brief, and if you want to target to somebody.
Sir, you have told that there is increasing addiction of tobacco and this alcohol in the pediatric age group, but I would like to suggest that drugs like cocaine is increasing in the use. Can we have some idea or any survey related to it? We want to know. The second thing is, as we have a warning on the tobacco products that this contains death, this may cause death and likewise. So can we have a warning on a fast food or carbonated drinks that it is having more sugar or salt or say trans fat in it? So that can be another idea.
Yeah, the direct answer is yes, but we will try to look into the data and tell you how serious this issue is. It actually comes under mental health program. Currently, we are looking into. Maybe we'll happy to catch up bilaterally to answer to this question, but the answer is yes.
On substance abuse, if I can add, we just published the data on LIMAC countries and prevalence of cocaine-related coronary artery disease. Surprisingly, in LIMAC countries, 67 countries, GBD, Global Burden of Disease data sets, prevalence was 3%. It's not small. 3% of patients in LIMAC countries had cocaine abuse, probable contributory etiology in occurrence. And if you extend it to all substance abuse, it is even more. It's even more. And other problem that I actually wanted to highlight is the cough syrup addiction. A lot of patients will come to you by one or the other reason. They would be prescribed dextromethorphan as a cough syrup. Or a lot of times, dextromethorphan cough syrup is given over-the-counter prescription without a prescription by the pharmacist or the local doctor. And then the patient keeps taking it because of the sense of well-being that sets in with the substance abuse that sets in with the opioids that are there. So that's another big addiction, because I think a lot of times I always suggest that something, even for that matter, painkillers, knee, joint pain, a lot of patients would be on opioids as an analgesia. And then they would not take it for knee pain. They would take it because the day they don't take it, they don't feel okay about it. So that's the other issue that is also contributory to huge extent in occurrence of events in cardiovascular events.
Thank you. Maybe we can take the last question from Kulkarni sir.
I don't have a question. I have a few points to make. Excellent presentation by all the speakers. The most important point was highlighted. 70% of the problem is with the food. I say it is 80%, not 70%. And Hippocrates, 2,000 years back, more than 2,000 years back, said, let food be thy medicine. Okay? 5,000 years back, Bhagavad Gita said, Natyashnatastu loyogosti nachaikanta manashnataha nachati swapna shilasya jagrato naivacha arjuna. The one who eats too much, the one who eats too less. The one who sleeps too much, the one who sleeps too less. That means the whole lifestyle has been prescribed there. What we have adopted is a Western food style. Okay? The ultra-processed foods, easy. Okay? So we have to understand this. Unless we change our lifestyle, prevention is the only key. Okay? Treatment is not at all. It is just palliative, I say. But unfortunately, all clinical subjects are glamorous in our country, and unless we make prevention, okay, incentivized, 20% of the population, child population, is already pre-diabetic. If a community medicine man goes to the community and makes that pre-diabetic person into normal person, nobody appreciates. But if the blood sugar is reduced from 400 to 150, okay, there is a big appreciation. I'm not criticizing any clinicians. What I'm saying is prevention, prevention, and prevention is the only key. Thank you.
Thank you, sir, for this insight.
One last comment. I think, sir, beautifully highlighted by you. And the other point that I want to add to it is the rule of averages, which I usually say is a problem as a race as we have evolved. Look at the LDL. 190 used to be normal. Now they say 70. Why? Because they decided, let's find out average in the community. Whatever is average is normal, anything up. But as a community, we have grown in a level where the averages are above normal. So I usually give an example. This is true for sugar, for blood pressure, for cholesterol, for whatever you consider. I give an example of a village of thieves. There used to be a village of thieves, and then they decided that we are being labeled as village of thieves, so let's sit down and decide who is a thief and who's not, and they calculated averages. So anybody who did less than 3 robberies a month was considered as not a robber. Unfortunately, that has happened whether you are diabetic, hypertensive, dyslipidemic. I think monkeys, chimpanzees, orangutans, aborigines, adivasis, tribals, their LDLs were always less than 70. where blood pressure were always less than 120, sugars were always less than 100. It's we that we thought that the westernized averages are averages that we need to follow. Same was with the BMIs and other cutoffs. So those are important points that you brought, sir.
Yeah,
Thank you.
Thank you. So what a fantastic end to this entire thing. Our panelists would be really happy to address a lot of questions, and the tea break, in the interest of time, maybe we need to now wind it up. So I would request our colleagues to felicitate our guest. But before we go ahead with that, I would thank Dr. Narayan and UNICEF for supporting this entire plenary. It was really great level of advocacy that these people are bringing, and for a very important topic. So before we leave, I think it is all credit goes to you and this entire team of experts who can come down, who have flied from different area also for this particular event. So thank you very much, team, IAPSM, and I think IAPG Director, Registrar, everybody who has backed upon this thing. I would like to thank them. But we have a very important event after this, so let us move towards felicitation. I would request and I will invite Professor Kulkarni on stage to felicitate Dr. Narayan. So as a part of this center, I think we are very much open to collaboration. So anybody who want to work in NCD, very happy to come. Yes, sir. So then I would request Dr. Purushottam Giri to felicitate Dr. Kamal Sharma. I would invite Dr. Bhavesh Modi to felicitate Dr. Jhalak. And our registrar, Professor Anish Sinha, to felicitate Dr. Radha. And I would invite Dr. Vehan to felicitate Dr. Nikhil Modi. So maybe let us gather for a group photograph. With this, we quickly move to the next session. Sorry for the inconvenience related to timing.
Our next session will resume in another 2 minutes. We would request the delegates to refresh themselves with a cup of tea or coffee. Ladies and gentlemen, we move on to our next segment. We request all the delegates to please take their seats. I welcome you back to our next segment, the prestigious Shri H.M. Patel Oran Presentation. The Shri H.M. Patel Memorial Trophy is an annual award given to the winners of the oral presentation at the scientific session of the IAPSM GC Annual Conference. The trophy is given to encourage research interests in junior IAPSM members. Today, we have 6 enthusiastic participants with us. I would like to invite on stage our chair for this session, Professor Pradeep Kumar, who is a professor at the M.K. Shah Medical College. Professor Pradeep Kumar has more than 40 years of teaching experience at various medical colleges in Gujarat and has served as a national and state-level trainer, coordinator, and evaluator for various national health programs. Professor Kumar has been conferred with an inauguration by the IAPSM Gujarat chapter and the Best Teacher of Public Health Award by Gujarat University. He is the recipient of the Fellowship of the Indian Association of PSM and the Indian Hypertension Society. He also served as the additional project director of the Gujarat State's Aid Control Society. Our judges for today are Dr. Himanshu Nigandhi, Director, Public Health Foundation of India, Delhi, and Dr. Animesh Jain, the Professor, Community Medicine at Kasturba Medical College, Mangalore. I now request the Chair to take over the proceedings of this session and introduce our presenters.
Good afternoon to all of you. Technically, it is now good afternoon. So I welcome all of you in this session. I welcome the judges and the presenters. As per the list, I have got 6 names for this session. Is the time limit 7 plus 2? 7 plus 2. So the presentation time is 7 minutes. Try to finish off within the 7 minutes because this also invites some marking, whether you finish in time or not. 2 minutes from discussion point of view. Judges will ask first the questions, and then it will be open to the audience. So let me first take the attendance. Dr. Aromal is there? Please raise your hand. Oh, thank you. Dr. Rajdeep? Sure. Nirmika? Yeah. Ruchit Nawal? Nitya Kumari? Niyat Kumari? Sure. And Shaili Singh? Shaili? Okay, fine. So I first invite Dr. Aromal for the presentation, a resident from Government Medical College, Surat. Topic is determinants of delay in the presentation, diagnosis and treatment of cervical cancer, patients in a tertiary care hospital, a mixed method study. Start, please, huh? Sure.
So good afternoon, everybody. I'm Dr. Aromal, third-year resident of GMC Surat. So my topic is determinants of the delay in the presentation, diagnosis, and the treatment of cervical cancer patient in a tertiary care hospital, a mixed method study. So as we all know, cervical cancer is the second most frequent cancer. This is not moving. Slide is not moving. Okay. Okay. So as we all know, cervical cancer is the second most frequent cancer among women between the age 15 to 44 years in India. So current estimates that every 8 minutes, one woman dies of cervical cancer. So what could be the reason of this high mortality? Diagnosis at the advanced stage, which may be due to the delay in the presentation or due to delay in the diagnosis, plus delay in the treatment or poor access of the management. So my aim of the study is to improve the cervical cancer management by addressing the various stages of the delay with the objective to document the delay in the presentation, diagnosis, and the treatment of the cervical cancer patient and associated factors of it, and to identify reasons behind this delay. And there is also a qualitative component is also there, that is to explore the symptom appraisal and the help-seeking behavior among the cervical cancer patients who have experienced the delay. So now coming to what is patient delay, diagnosis delay, and treatment delay. So from the onset of the symptoms to the first consultation of the doctor, that interval, it is called as patient interval. And if it exceeds more than 90 days, it is called as patient delay. And from the first consultation to the final diagnosis, that interval, it is called as diagnostic interval. And if it exceeds more than 30 days, it is called as diagnostic delay. And from the final diagnosis to the initiation of the treatment, that interval, it is called as treatment interval. And if it exceeds more than 15 days, it is called as treatment delay. So these are the timeline of the delays: 90 days for the patient delay, 30 days for the diagnostic delay, and 15 days for treatment delay. So coming to the methodology, I have done an explanatory mixed method study in 142 cervical cancer patients who have sought treatment from the Lion Cancer Detection Center from April 2024 to September 2024, considering inclusion as well as exclusion criteria, and recruited through convenient sampling. So sample size was calculated using OpenAP software with p-value 89.7%, which was taken from the previous study. So what I have done, that I have done a cross-sectional study in 142 cervical cancer patients, and from those patients who have experienced delay, I have recruited them for in-depth interview, which were 10 in number. So the data was analyzed in SPSS for the quantitative study. For the qualitative study, I have done the deductive analysis with the code and themes were generated. So this is a theoretical framework which I have used for the study, that is model of the pathway to the treatment. So now coming to the observations. The median patient interval was 67 days, in which the patient delay was reported in 47% of the patients. And to explore the reasons behind the delay, I have done the qualitative study with themes generated on symptom appraisal and the help-seeking behavior. So the first theme was false perception and interpretation of the symptoms. Many women has misinterpreted the symptoms that has led to the delay. For example, if it is a postmenopausal bleeding, they will consider as a return of the menses after 2 to 3 years, which they perceive as normal. And if it is a post-coital bleeding, they will blame the husband and even ask the husband to consult the doctor. And some assume it as the medication that they are taking for a long time. For example, TB. So all this has made the patients to make the symptoms changes very insignificant for them. Next thing is lay consultation and disclosure of the symptoms. Some people have shared their symptoms to their people, but they have misguided them by belittling or normalizing these symptoms. But many of them have not shared their symptoms either because of the stigma or because of the lack of social connections. The next is trial of the traditional medication and self-help practices. Many women has blindly relied on the traditional medication, so desi dawa, till the aggravation of the symptoms that has led to the delay. But some depend upon the self-medication practices or home remedies that has led to the delay. Next, final theme is perceived barriers of the healthcare, which include financial troubles, lack of accessibility to the healthcare because of the long distance of the travel, caregiving responsibility of the woman that has forced her to ignore symptoms even though the symptoms are excessive. So these were the reasons which I explored through the qualitative study for the delay in the presentation. Now coming to the diagnostic delay, the median diagnostic interval was 15 days, in which the diagnostic delay was reported in 35.9% patients. And the most common reason for the diagnostic delay was symptom misinterpretation and the wrong diagnosis by the consultant, which was reported by 46.15% patients, followed by financial troubles and the long distance of the travel. So I have done the chi-square test to find the association of the healthcare factor variables with the diagnostic delay. What I have found that the initial consultation at the local clinics, no cervical examination the first visit, misinterpretation of symptom by the consultant have significant association with the diagnostic delay with p-value less than 0.05 and odds ratio more than 1. And the initial consultation with the gynecologist has also a p-value less than 0.05, but the odds ratio less than 1. Now coming to the treatment delay, the median treatment interval was 20 days, in which the treatment delay was reported in 58% patient. And the most common reason for the treatment delay was the delay in availing health insurance, which was reported by 24.63% patients, followed by financial troubles and fear of medical treatment or interventions. So I'm concluding like that. The delay in the presentation was mainly because of the lack of awareness that has led to the trivialization of the symptoms and the stigma associated with it. But the delay in the diagnosis, it was not because of the patient factors, but it was because of the healthcare provider factors such as misinterpretation of the symptoms and insufficient examination. And the delay in the treatment, it was mainly because of the health system factor, that is challenges in the accessibility of the health insurance, followed by the financial troubles. So my recommendation, to address the lack of awareness, we have to enhance the initiative to build awareness. We have to strengthen the cervical cancer screening for the early detection of the cervical cancer in order to avoid the delay in the presentation. We have to build the competence, we have to build expertise, we have to upgrade the skills of the healthcare providers in order to avoid the diagnostic delay. And for the timely treatment, what we have to do, universal accessibility, enhanced coverage, enhanced awareness of the PMJ is required to address the treatment delay. So these are my acknowledgements, study participants, the staffs of Lung Cancer Detection Center Surat, HREC GMC Surat. These are my references. Thank you.
Thank you, Dr. Aramal, for addressing to a very important, especially the specific issues related to that problem to be addressed. Secondly, for finishing within time, I may ask learned judges to put up the questions for.
Thank you, Dr. Aramal, for the presentation.
Thank you, sir.
Could you tell us a little bit more about the analytical framework that you've used for your qualitative data?
Yeah, sure.
How did the teams actually?
Yeah, yes. So this is the model of the pathway to treatment, the theoretical framework which I have used to study. So what I have done, in the model of the pathway, the treatment, there are three things are made. There is event is there is a process is there is an interval is there. And the first thing is that the first interval, it is the appraisal interval and the help-seeking interval, which was the main focus of my in-depth interviews. Appraisal means that the patient will have some symptom change, but they don't know it is because of some disease. So the time interval, they have started the symptoms and they understood that, yeah, this is because of the disease. That is called as appraisal interval. For example, in in-depth interview, I have told that is menses after menopause. They know bleeding is going, but they conceive it as the responsible for because of the menses, not because of the cervical cancer. For a whole long time, they will consider it as normal. So that period is called as appraisal interval. Even though they have symptom, but they consider it as normal, it is called as appraising interval. Help-seeking interval means that they know it is a problem, but they have to consult the doctor. What had made the responsible to delay in that help-seeking interval? For example, they know they have to consult the doctor, but because of the lack of accessibility of the healthcare or the financial troubles, they couldn't consult. So that contributed to the help-seeking interval. So this is what I have inspired from this theoretical framework that I have put on my in-depth interviews.
Just a quick two things. One, I saw that ethical issues you put up informed consent. I believe you would have taken an approval of the ethics committee.
Yeah, sir, sure, sir.
Second thing, how did you decide on these 10 women for the qualitative interview out of the 142 or so?
Listen, the thing is that from the patients who have experienced a delay in the presentation, those women who have those presentation was more than 90 days, I have recruited for the interview.
There were only 10 of them. There were only 10 of them.
No, I have conducted till the saturation. By the 10, I got saturations.
Thank you.
Okay.
So, audience, very quick one question. Yeah, please.
You have mentioned in the conclusion that the misinterpretation by the symptoms by the consultant and insufficient examination by the consultant. So you have taken the interview of beneficiaries only. So how can you come to this conclusion?
So we can see the medical reports from what they have taken. What I can tell that in most of the cases, when the woman will complain of the vaginal discharge and go to the consultant, they will provide the symptomatic management only. That is the first thing. And they will treat for the symptomatical management for the 2 to 3 months for a long time. And the second thing is like that, in the generalist, let me tell of the generalist, they will do USC also. So the USC is not a reliable investigation for the cervical cancer. And the most of the situation which I feel it is very pathetic is like that they have done the USG, they're laid on the USG, but they are carrying the cervical cancer, but the USG is normal. In some cases, they have taken the pap smear also, but that also come to as the normal. I think all this has led to the wrong diagnosis.
But the sample cells you have chosen is, that is not the purposive sampling you have taken, right?
I've taken the convenient sampling for the convenient sampling for my quantitative study. For the qualitative study, I have done the purposive sampling.
Thank you. The time is over, so we'll invite the next. Thank you, Dr. Arman. May I ask the people who are managing this AV system to put a timer for 2 minutes after the presentation is over? Huh? So I invite the next speaker. Dr. Rajdeep, Resident Doctor from PDU Government Medical College, Rajkot. His topic is analysis of reasons for pending and rejected Pradhan Mantri Jan Arogya claims at secondary and tertiary care public health institutions in a district of Western India. Please start.
Myself, Dr. Adip Chaudhary. I'm secondary resident in PDU Medical College. I am presenting analysis of reasons for pending and rejected Pradhan Mantri Jan Arogya Yojana, that is PMJ claims, at secondary and tertiary care public health institutes, PHIs, in a district of Western India. India had come up with the most ambitious health scheme ever, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, ABPMJ, a government-sponsored health insurance scheme in 2018. There are 3 online systems: Beneficiary Identification System, BIS, for beneficiary enrollment, Transaction Management System, TMS, for claim processing, and Central Grievance Redressal and Management System. Gujarat had approximately 1,800 PHIs out of 2,600 M-panel PMJ hospitals, but the claim money of PHIs was only 200 crore, excluding the Apex hospital, out of the total 4,000 crore in the financial year 23-24. Government of Gujarat had outsourced beneficiary facilitation agency at district level, which contained some Pradhan Mantri Arogya Mitra, PMEMs, which is discontinued now, and PHIs are hiring the PMEMs on their own now. Mehsana district has enrolled target-wise highest PMJ cards in Gujarat state till July 24, and then only 8.61% in beneficiary were pending for enrollment in BIS, whereas the state pendency was 25%. So there should have been list issued at the level of BIS, but most at the TMS for many claims to be pending or rejected. So the objective of this study was to know the proportion and to analyze the reasons of rejected PMJ claims, to know the proportion and to analyze the reasons for pending PMJ claims, and to recommend possible solutions for secondary and tertiary care PHIs. It was a retrospective analytical observational study in a district hospital DH Mehsana and a community health center CSC Langanaj in Mehsana district in August 24 of all PMJ claims initiated in 6 months, that is from January to June 24. This study included one tertiary care PHI, a hospital, and a secondary care PHI, a health center, to get a comprehensive picture of health system. It included DH Mehsana and CSC Langanaj to purposive sampling, because these PHIs were the highest claiming in those categories of DH in the first 6 months of 24 and CSC in the financial year 23-24 in the whole of the state. It got access to the line list of all the claims initiated in this study period, along with the reasons for rejection and pendency. Data collection were made through the MS Excel 2019. Before going to the results, I would like to go through the TMS workflow. So once the patient will come to the hospital, it will get registered by the PMM. Then the patient will get diagnosed and will get an admission in the hospital. Then the medical coordinator, that is the medical side doctor, will submit this claim in the TMS to the insurance side, that is called the pre-auth panel doctor, in short PPD. The medico can cancel the claim at that level, but if it processes, then PPD can approve, reject, and give some query and make it pending also. Once it is approved at the level of PPD, then patient will get treatment, medical or surgical, and then patient will discharge. Again, after discharge, the medical coordinator will submit the claim to the claim processing doctor, that is called CPD. Again, CPD can approve, reject, and make it pending with the queries. And then it goes to the paid part. So let us go to the results, proportion-wise and reasons-wise. So let us go for the proportions. The numbers of claim, 54% were paid, whereas 27% were PPD rejected, 9% were PPD cancelled, 8% were CPD rejected, and 2% were pending in CHC. In DH, it was 69% were paid, 5% were PPD rejected, 8% were PPD cancelled, 4% were PPD approved, 3% were CPD rejected, and 11% were pending. If you go through the money involved in those claims, only 59% in case of CSC and 60% in case of DH was paid, whereas the 40% were either cancelled, pending, or rejected. So just summarizing the results in case of proportion, so it is 33% out of the 92% process claim were either pending or rejected at CHC, whereas 28% out of the 88% process claim in case of DH were either pending or rejected. Let us go to the reasons for that. For PPD rejection, the most common reasons at CSC were document submission pending, false package selection, investigation, delayed or no query resolved, among others. At DH, false package selection, document submission pending, duplication, delayed or no query resolved, among others, were the common reasons. For CPD rejection, the most common reason at CSC were pending investigation sheet, treatment sheet, vital chart, patient photograph, among others, whereas at the level of DH, patient photograph, discharge summary, OT note, culture sensitivity, and histopatho examination were common reasons, among others. For pendency, the common reasons at CSC were patient photograph, ARV dates, USG report pendency, whereas in case of DH, it was patient photograph, discharge summary, dialysis photo, treatment sheet, culture sensitivity, histopatho reports, and OT notes, among the others. So just summarizing the reasons for that, we can see that at the level of PPD, both CSC and DH has somewhat common reasons. At CSC, PPD rejection and CPD rejection reasons are common, and at DH, the CPD rejected and the pendency reasons were more or less common. So I would like to conclude this result as around 8 to 9% were cancelled by the hospital itself. Around 1/3 claim money were either rejected or pending. And at PPD level, there was false package selection, duplication mainly at DH, and pending document for diagnosis were common reasons. At CSC, the pending investigation was the most common reason. And at DH, pending documents of treatment like patient photograph, discharge summary, OT note, culture sensitivity, histopatho reports were the most common reason for CPD rejection and pendency. So based on this conclusion, I would like to recommend there should be a specific checklist listing all the necessary documents should be attached with the case file itself. Also, there should be provision of standard treatment guidelines to all committees at the department level, whatever they are claiming for. And along with that, it's a regular rechecking, monitoring, and review system should be developed. And specific recommendation at the level, there should be a training and sensitivity all PMMs and medical coordinator by the insurance company and state health agency. And CS should be equipped with the necessary labs, or it should be able to tie-ups. And DH should be a structured, dedicated PMJ claim team, which comprises of medical and paramedical team, along with the financial staff. A signed person should be there for specific document submission. It should work as a link between hospital staff and PMMs to solve all these queries. Swasthasya Swasthaya Rakshanam, Aturasya Vikara Prasmanam, as stated in Charak Sanhita. The first part, Swasthasya Swasthaya Rakshanam, means the one who is healthy should be kept healthy. That is the first part of Ayushman Bharat, Ayushman Arogya Mandir. And Aturasya Prasmanam, that is second part, means who is ill should be managed or cured. That is the second part of Ayushman Bharat, that is PMJ. As stated one, તમે અમારી મુશ્કેલીઓ સાંભળનારા પ્રથમ વ્યક્તિ છો. Thank you.
Thank you, Dr. Rajdeep, again for a very important topic and finishing with. Ask the learned judges to put up the questions.
Dr. Rajdeep, when we were looking at your presentation at the district level, others seem to be a very large category. Could you elaborate on what was there in the others and why is it important for you?
So it depends. It was from the different departments had different problems. But the ultimate theme was that document for pendency. Like in case of orthopedic, there was barcode on invoice of the implants were pending. Like of general medicine, the iron sucrose claims were raised even before the completion of the full doses, and they initiate the claim after the first dose itself. In case of ARV vaccination, they give first dose and they initiate the claim. So likewise, there were many claims in other category as well, but those were specific to that particular departments. But ultimate theme of all of the reasons of that there was somewhat pendency of the documents of the diagnosis at the level of CPD and pendency of documents of diagnosis at the level of PPD. At PPD, there were other reasons like false package selection and duplication as well. Yes, sir.
Do you think this can have any implications on the recommendations, the general recommendations that you've suggested towards the end?
Yes, sir.
Could you elaborate how?
Sir, ultimately, the things is very common. Ultimately, there should be there are two kind of recommendations. At CSC, the secondary or the primary level, the recommendation would be like they mainly lack the investigation services. So if we equip those services, then this could be solved at larger level. Whereas in case of district hospital and medical college hospital, which is a tertiary care, there should be a structured dedicated team because there will be many 18 different departments in those things, and they have to submit particular documents. Thank you, sir.
So no questions.
Dr. Rajdeep, do you see any limitation of your study?
Sir, first of all, it's a purposive sampling.
That's
yeah. So, sir, but I try to select those institutions in those particular category which was performing highest in the state, so that we can get along the highest possible sample size and the rejected claims and pending claims, so that we can analyze more and more, whatever the reasons we can come up.
But you are taking only government health facilities.
Yes, sir. I think
that is also a limitation.
Sir, that I already stated in the introduction.
Okay, fine.
That it was
I
only.
missed that.
Yes, sir. Thank you.
That's good. And how you differentiate this pendency with this rejection? Because something is remained pending for a long time.
Sir, there is something called turnaround time, TAT time. Every step has to be finished within a stipulated time period, whether it is 24 hours, whether it is 6 hours, whether it is 7 days. In case of PHIs, they were even extended the stipulated time for document submission, which is private facilities, it's 7 days. In case of government facilities, 13 days.
Yes. Any question from the audience? Dr. Aparajita, please.
Comment. In your observations and present display in form of charts, you could have separated the patient side reasons for delay and the service side reasons for delay. That could have given us a better understanding of where the major
yes,
issue is
from
patient side, or the recommendation could have been better in that case.
Ma'am, it has hardly anything to do with the patients actually. It is everything to do with the team called beneficiary facilities, which is discontinued in our state. Ma'am, the patient photograph has to be submitted by the staff itself and has nothing to do with the patients. Patient just has to come up with the Aadhaar card or say PMJ card. And once it is registered by the PMM, then it has nothing to be provided by the patient side. It has nothing to do with it. It is only the hospital staff, the administrative staff, as well as the technical staff. Those has to finish those demands of the insurance company in the software called TMS. Then they can claim the full money. Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Any other question? So, thank you, Dr. Raj.
Okay, thank you, sir.
Sure. We invite the next speaker, Dr. Monica Patel from GMAS Medical College. The topic is antenatal breastfeeding counseling to improve the rates of early initiation and exclusive breastfeeding among primary gravida women in a medical college hospital of Ahmedabad city. Nirmika, please start.
So, good afternoon, everyone. Myself, Dr. Nirmika Patel, and here I am to present the antenatal breastfeeding counseling to improve the rates of early initiation and exclusive breastfeeding among primary gravida women in a medical college hospital, Ahmedabad city. So, breastfeeding is a very cost-effective intervention for lowering childhood morbidity as well as mortality. And NFHS 5 data shows that there is early initiation within 1 hour is 37.8%, and exclusive breastfeeding is 65% in Gujarat. And most common reasons for non-exclusive breastfeeding are shown here, and some of these issues can be resolved by early informing the mother during antenatally. So, our study objective was to estimate and compare the rates of early initiation of breastfeeding and exclusive breastfeeding among counsel and non-counsel mothers. It's a hospital-based intervention study conducted in a GMERS Medical College and Hospital, Sola, Ahmedabad. And we have targeted antenatal women came to obstetric OPD, and among them we have selected primi gravida antenatal women in our study between the January to March 2023. First of all, we have calculated a early initiation rate in a primi by doing a pilot study in a PNC ward, which was 14%. And from that, we have calculated sample size for each group. It's a 117. And considering 10% loss to follow-up, we have rounded to 130 in each group. So total 260 primi gravida women were included in our study. After taking IC approval, we have selected 260 primi gravida more than 18 years of age, between 28 to 32 week of gestational age, women from the obstetric OPD. And from the Monday, Wednesday and Friday OPD, we have enrolled women in an intervention group. And from Tuesday, Thursday and Saturday OPD, we enrolled the mother in a control group. So for intervention group, we have given them 2 antenatal breastfeeding counseling session by trained health worker. First at the time of enrollment, and second before the completion of 36 week of gestational age. The counseling session focusing on the breastfeeding advantages, correct latching technique with the demonstration with the doll and the breast model, and the issue discussing some common breastfeeding issues. We have followed all the 260 women at 3 different point of time. Before that, we have excluded preterm delivery as well as those who require, babies who required more than 1 hour of NICU admission. First follow-up within the 3 days of delivery before the discharge, second after completion of 3 months of delivery, and third after completion of 6 months of delivery. So our study observation shows that the socio-demographic details of both the groups are comparable in the terms of age group, the education of mother, occupation of mother, and the religion of the mother. We have also observed the initiation of breastfeeding after delivery. So in an intervention group, it was 24%, and while in its a control group, it's a 14.9%. Prelactal feeding practices was also observed during the first follow-up. So it was 8.8% in an intervention group, while 15.7% in a control group. We have observed the exclusive breastfeeding rate at all 3 different points of time. So at the time of first follow-up, it's a 91.2% exclusive breastfeeding rate in an intervention group, while it's a 84.3% in a control group. During the second follow-up, it was 86.5% in an intervention group, while a 69.3% in a control group. While at the time of third follow-up, it was 68.1% in an intervention group and a 38.4% in a control group. We also include the reasons for not giving exclusive breastfeeding, but most of the mother given non-specific reason to start the complementary feeding before 6 months. Some common other reasons are prelactal feed given at the time of birth, perception of low milk supply, and other reasons include twin baby and the mother illness, child illness, as well as mother-child separation condition. We have concluded that the breastfeeding counseling by trained lactation counselor during the 3rd trimester of pregnancy significantly improve the breastfeeding outcomes during the first 6 months of life, and existing antenatal breastfeeding counseling services are poor in a study setting and it's need to be strengthened. So we recommended the appointment of trained lactation counselor for antenatal breastfeeding counseling for a pregnant woman during last trimester, antenatal visits, training of existing obstetric OPD staff for antenatal breastfeeding counseling, as well as the breastfeeding counseling activity should be captured in a Mamta card and in the antenatal care of last trimester. So these are my references. We are thankful to SHSRC Gujarat for financial support, Department of Obstetrics and Gynecology, Department of Pediatric Community Medicine, our Dean sir and the Superintendent ma'am and study participant. Thank you so much, and thank you for your attention.
Thank you, Dr. Nirmika. Good presentation. May I request judges to put up question? Is there any?
Thank you very much for the presentation. Nirmika. I have 2 questions for you. It will be helpful for us to understand when you said there was an intervention package of counseling. What was the package?
Yeah.
So you would want to clarify how was it delivered, how frequently was it delivered, was it throughout the antenatal period, you had 3 periods of follow-up, Was it continued during the period of follow-up as well? That's the first question. Would you want to take that?
Okay. Sir, in an intervention group, we have conducted a 2 antenatal session. The first session at the time of the enrollment, and we have enrolled the woman between 28 to 32 week of age. And second counseling session was delivered before the 36 week of completion of 36 week of gestational age. And each session will last between 10 to 15 minutes for each mother, and mainly focus on the breastfeeding advantages, discussing about the common breastfeeding issues, demonstration of latching technique, correct latching technique with the doll and the breastfeeding model. And our main counseling material prepared on the basis of these 45 breastfeeding counseling points.
Sure. That would have been helpful if you could have shown us who delivered the package, how
So
frequently.
it's delivered by trained health worker, and those health worker trained by us only, because we all are IYCF trainers. So.
Okay. My second question is, you had equal numbers in your intervention and your control group.
Yes, sir.
In your design, you mentioned you did an intervention study. What type of intervention study have you done here? You got absolutely equal numbers?
Yeah, sir, intervention is a antenatal counseling session. As such is an intervention.
Okay, then my question is, how did you get equal numbers in your intervention and control group?
Sir, we have taken the sample size calculation was done by OpenAPI Info software web-based sample size calculation. For that, we have 14% primary mothers early initiation of breastfeeding rate as pilot getting from the pilot study, and we have assumed that we can get improvement up to 30% by taking a 80% of power of study and 95% of confidence interval. So we get 117, and in this we have included 10% of loss to follow-up.
So may I?
Yeah.
So one quick observation. I saw that prelactal feeds was quite high in both the groups.
No, so it's 8.8% in an intervention group, and in a control group it's around 15%.
Yeah, so but 8%.
Yeah, it's a high,
comparatively.
exactly, sir.
So I was just wondering, because even in the intervention group you had, I mean, I didn't notice 8 point whatever, but it looked like somewhere very closer.
Sir, prelactal feed is not just only a honey or jaggery water. It can be a formula feed or a water. Even anything other than colostrum given to the baby is considered as a prelactal feed. So it's a quite commonly seen prelactal feeds are a formula feed or water. Then it's animal milk and jaggery water and all that.
Thank you.
Nimika, I would like to ask one small question. What exactly was given to the control group? Because you talked about the intervention, but was there any package given to the control group women also?
In a control group, there is a conventional antenatal care, just measuring a BP and all that. Because there is no any strict protocol to counsel each and every mother in a solar.
You mean to say they have not been counseled?
No.
They have not been informed about exclusive breastfeeding or anything?
No, but they have given a postnatal help if they required for breastfeeding.
Fine. Now, on a lighter side, just let me know, you picked up the patient from the alternate days.
Yes, sir.
It was to ensure randomization?
Yes, sir.
So do you think it will really do the
No, it might have a limitation.
What limitation? That is what I want to know.
Yeah, the patient comes through on a Monday, can become on the another day as well, but we have enlisting the patients who have. So we take care the second session.
No. What I will say, the patient coming on Monday will be different from those coming on Saturday.
Yeah, definitely, sir.
What difference?
So because the patient have allotted they have to come on this day for a unit wise, the allotment is there. That's why. Yeah.
Any other question from audience? Quick. Thank you. Thank you, Nirmala. Now next is Dr. Ruchit Nawal, President from BJ Medical College, Ahmedabad. Stolen smiles tracing the merciless progression of oral lesions in tobacco users of Gujarat. Dr. Ruchit, please make your presentation.
Good afternoon to the research community. Well, myself, Dr. Ruchit Nawal. I am presenting the original research article today, Stolen Smiles, tracing the merciless progression of the oral lesions in the tobacco users of the Gujarat. Let's identify who stole the precious smile. So the background is, as per the ICMR 2021 report, we can find at the Gujarat regional context, the tobacco exposure among the male and female, and that 1,43,759 was annual cases, and out of that, male tobacco users in the Gujarat were 38.7%, and 3.2% predicted as a cancer mortality in NCDs. The key observations were the significant gender disparity in the tobacco-associated cancer burden, and the oral cavity represents the highest proportion in tobacco-associated cancer. It is the second most common cancer identified after the breast cancer. The rationale behind doing this study is the lack of the temporal relationship, where we establish to establish a temporal relationship between the exposure and the pathology of the oral lesions, to identify the early warning signs and the progression patterns, and to detecting the dramatically improving the survival rate, how to identify that key points. So the prime objective was to know the prevalence of the various oral lesions among the tobacco users of the Gujarat, relationship analysis by the frequency of the use, duration of the exposure, and the years of the exposure. And the most novel approach we have used is the critical point analysis to identify that point after that the development of the lesion increases dramatically. The study design here is the cross-sectional study conducted at a GCRI Ahmedabad for the 2 months span, that is Jan to Feb 2024, after all institutional ethics committee approval. Total participants enrolled by the consecutive sampling technique were 310 by the inclusion criteria, which are the relatives of the cancer patient who have been visited the cancer screening OPD and have consented for the participation, and already the relatives or the patients who are having the history of the oral cancer or where the patients were not undergo the oral well-scope examination have been excluded. So the examination procedure we have used is the conventional examination and well-scope examination. Each participant underwent both of them side by side. And in the conventional examination, the approach is the white light, which is based on the reflection property, and the well-scope is a novel instrument right now used in the selected cities only. And in this well-scope, it is based on the fluorescence property of the light, which can detect the subtle mucosal changes also. The data collection process was adapted from the WHO Global Adult Tobacco Survey, and it is defined meticulously by the Community Oncology Department faculty, where the key findings or variables we are gathering are the demographics, tobacco use, and the clinical finding. The statistical analysis we have done here is descriptive, logistic regression, change point analysis, and Kaplan-Meier analysis by the R software, latest version, p-value less than 0.05 taken as a significant. So the observations: 310 participant. Out of that, 300 were the males, that is 96.8% male predominance, mean age 42.3 years with a standard deviation of 11.7 years. The distribution of tobacco consumption forms are 42.9% gutka, which is a maximum, and least is a 6.4%, that is combined use. As you can see, we have identified the 6 most common lesions in the patients, which are the starting with the most common is a discoloration, that is 55.86%, and the lichen planus, that is 4.48%, which is least common seen among the that our participants. As you can see, that participants were 310, but the distribution of the oral lesions are 469, which means one patient may have the multiple lesions. The association between the tobacco use patterns and the oral lesions, we have found a statistical significance because the frequency of the use, that a person who is having the frequency of 1 to 5 times, that is total users are 242, out of that 20 had some form of lesions, out of the 6 lesions which I listed, that is 85.95%. But as the frequency or the category increases, that is more than 10 times, it poses that is 31 users out of that 30 were having the lesions, that is 96.77%, p-value significant 0.053, and the duration in the mouth, that is also we have found highly significant results, that is p-value 0.002, that is a person, you can see, keeping the tobacco for more than 30 minutes, that is 9 users, all the 9 had the lesions, and in the less than 5 minutes category, 131 users had users with the lesions were 108, that is 82.44%. Let's conducted the multivariate logistic regression analysis. The 3 variables we have seen: the years of exposure, frequency of the use, and the duration in the mouth. All are the statistically significant results. But what we additionally I want to comment is the years of the exposure shows the strongest statistical significance, and the frequency of use has the highest magnitude of the effect. That is, each additional year increasing the risk by 8%, higher frequency increases the risk by 45%, and the longer duration increases the risk by 29%. The most novel approach here uses the segmented regression model. There is a change point analysis, that the change point is 5.8 years. Before this 5.8 years, the annual risk increase was 2.3%. After that, the change point happens, and the 7.1% is annual risk increase in the patients. It was done by the segmented regression model specification, R square value 0.67, p value 0.01, and sum of squared residual is a tau is equal to 5.8. That is 3.09 X is a risk acceleration factor, and the critical window is 5 to 6 years. So accordingly, we have done the risk stratification, that is low risk, transition, and high risk based on our change point value we have derived. Next most important thing is the Kaplan-Meier curve. As you can see, from up to 5 years, there is steep decline and a narrow confidence interval, narrow confidence limits. And after that 10 years, you can see the wider confidence intervals and the somewhat equal or a flat line. So it shows that we have to cater our most efforts or interventions in the initial phase, that is 0 to 5 years. And the median time is 9.07 years. That is 50% have developed the lesion by that time. So the 5 years rate is 72% lesion free, 10-year rate 45% lesion free, and 9.07 is the median time. What we conclude here, the most novel point, that is 5.8 years, initial risk acceleration point. Median time 9.07 years, and accordingly risk progression timeline, we can say by 0 to 5.8 years, we can do the annual screening approach. In the accelerated phase management, we can do biannual screening approach, and high risk quarterly screening approach should be catered. What are the future direction I would like to see? This is a cross-sectional study. Further, if the study is continued, we can do a more longitudinal study, which is a major limitation we have found, and that would aid in the research more dramatically. These are my references. Thank you. Dhanyavad.
Thank you, Dr. Ruchit, for in time. Information is very well known, but you have used the data and statistics very well to generate a quality evidence which can be used either to develop IEC or to give to the administrators. Good attempt.
Thank you, sir.
We open for discussion. Learned judges, please ask the questions.
Thank you, sir. Taking cue from what you just said, it's well known. I just wanted to know what is so new or novel, and how does it compare with some of the other studies which have already been done in different parts of India?
Exactly. So what is the novel approach is that we are catering our resources every time on the period that it should be started early, it should be started late. But what if the national program from the government of Gujarat or any government policies cater to that specific point, which can be a game changer or which increases the risk accelerated, like 5.8 years identified by the segmented regression. It is based on the two things, that is pruned test, linear time test, and the BIC model. And these models detects exactly what, taking every change point as the crucial point, and after that BIC selects which is deducting the overestimating the effect. By this 5.8 years is a crucial, that before 5.8 years, if we can identify, the patient won't land up with these lesions, or we can see that by 5 years there's a 72% lesion free. So we can help or assist many such individuals with the tobacco users, because the Gujarat is a major center or the highest tobacco users we can find. Like.
So this screening was done by the same person or different people? And was there any training done for the person?
Exactly, yes, absolutely, sir. First of all, that the stringent training was done, protocols were followed, and as you can see in the examination procedure, I can say, slides are not moving. So the examination procedure, dental mirrors are used, white light is taken, and that lesions is recorded, and the lesions will be verified. And after that, again, that same patient, a well-scope study was done, and the lesions are recorded and identified. Before that, two medical officers were there, 2 resident doctors were there. All the entire team was in the lesion identification and cross-verification done with all these resource personnel.
One quick suggestion and
yes.
one question.
Yes, sir.
The suggestion is you showed usage frequency with the lesions.
Yes, sir.
You cross-tabulated it. Maybe you did it with frequency of consumption, you did it with the total number of years of consumption. Maybe you could also have shown us what is the different type of lesions that you get. So we had only presence of lesion, but all lesions are not of the same gradation in terms of the severity or the outcomes.
Okay.
So maybe that table could have been added. My question to you is, survival statistics, you talked about wider confidence intervals after 10 years. Could you elaborate the case statistically?
So the wider confidence interval is, what I can predict is two things. That is, maybe the sample size would be lower. First, second important thing which can be said is the variability is more. Thank you, sir.
Thank you.
Any question from the audience? Dr. Kosambia.
Okay, as you use the survival analysis, looking to your title and objective, what survival analysis that you have done?
Okay, so initially when we was drafting the entire research, when it was piloting stage, it was we are not like look for the Kaplan-Meier analysis or like that. But looking at the lesion, whatever collected was so enriched that we can see that what we have done, that the time period, initiation time period where the tobacco consumption was started, taking this time and current age, and accordingly we have divided that age group, that exposure years, and based on that it was very crucial to identify that yes, by this we can see the lesion free.
But my question is whether there is a need of survival analysis in this presentation, looking to your objective as well as title. That's my question.
Yes, sir. I felt
Otherwise,
yes.
we can use many statistics here. We can do, because we have large data set also, and we can do any analysis statistical. But is there any need here?
Yes, sir. I found a need because after...
Then you have not written here objective.
I think point is well taken. If you have any explanation, just give and let us move to the next question otherwise. Please.
Sir, I find that need is there because by that we can identify the 70% lesion free, 50% lesion free. That specific period should be identified to frame the policies and the protocol, health policies. That's.
Thank you. Any other question? So let us move to the next presentation.
Thank you, sir.
Thank you, Dr. Ruchit. Dr. Niyati Parmar, tutor from Medical College, Vadodara, identifying implementation bottlenecks for improving access to zero-dose children in GIDC areas of Gujarat. Dr. Niyati, please.
Good afternoon, everyone. I'm Dr. Niyati Parmar presenting Identifying Implementation Bottlenecks for Improving Access to Zero-Dose Children in GIDC areas of Gujarat. Immunization is the most cost-effective strategy to protect under 5 children. Although immunization coverage is improving in urban areas, also in rural area, but urban poor, such as migrants, are often missed out, as carrying out vaccination among this non-settled population is relatively difficult. And Ankleshwar GIDC is one of such area where conducting vaccination in this area poses numerous challenges to healthcare workers. So our study was carried out with the objective to identify zero-dose children among migrants, to identify implementation bottlenecks and barriers to access outreach health services, to develop area-specific strategies to improve immunization coverage in GIDC area in consultation with local stakeholders. A cross-sectional mixed method study was carried out between August 23 to May 24 in Ankleshwar GIDC area in collaboration with UNICEF. The data was collected both qualitatively as well as quantitatively. Qualitatively, data was collected by key informant interviews of beneficiaries, of guardians or parents, and focus group discussion, while quantitatively, house-to-house survey was carried out using convenient sampling and questionnaire was introduced. Coming to the observation of quantitative findings, total 73 families with 99 under 5 children were surveyed and interviewed from nearly a population of 23,000 people residing in underserved slums or the migrant population, of which 43 families are interstate and 30 families are intrastate migrants. Looking at the vaccination status of children, 17% of children are zero dose. 12% were totally unimmunized, 41% were partially immunized, nearly 48% were fully immunized out of eligible one, and 40% were completely immunized. Coming to the vaccination card detail, 61% of children of migrant families don't have vaccination card, and asking for the reason, they said that card was left at their hometown or village. When we ask the reason for dropout among these zero dose or the unvaccinated children, most common reason comes out to be unawareness of the vaccination center site in whole GIDC area, and second is session time clash with the working hours of the parents. The findings of qualitative data are divided mainly into the health system related challenges, beneficiary related findings, and health staff related findings. Let us discuss this one by one. First was unmapped population. This GIDC area is practically divided into two areas. One is industrial area, where there is unaccounted population with floating or the migrant population. Also, notified area where population resides, but it is very large population with frequent internal and external migration. Second major issue identified is about human resources. So the current model which is working in this GIDC area is PPP model, where one NGO named IGD is running RCH center and who is providing 3 ANM staff, but it is not enough for the current population, and government system is providing only ASHAs, not the male workers. Infrastructure and logistic issue. So currently only one fixed session is carried out, that is at the RCH center for whole entire GIDC population, and the outreach sessions are carried out only in the notified area. And it is also conducted in open area without proper seating spaces. Also, some migrants do not carry their Mamta card at the time of session, and they are not registered even in the TECO software. So it is very difficult to track them back. So these are the sessions conducted in open areas. This also poses accessibility issues as people avoid vaccinating their children in such open areas, particularly during monsoon and the summer season. Sessions are carried out only for the settled population, where migrant population either hesitate to go or it is far away. And clash of session timing with working hours is also there. This is the picture showing the areas we have visited. Nearly 70% of the upper, that is light pink area, is industrial area where scattered population is residing, and the dark color area where only 50 to 60% is population are residing, but most of the sessions are running in this area that is marked by the plus. This is the geo mapping of the area which we have visited. And another major issue is transportation, where ASHAs have to walk long distance to mobilize the beneficiaries. Vaccine has to be carried almost daily, as there is no cold chain point in whole GIDC area, and because only one fixed session site, all beneficiaries have to travel long, and sometimes beneficiary avoid to travel this long distance. Last issue which is there, that is vaccine hesitancy or resistance, along with lack of awareness among some communities. So, coming to the conclusion, out of total 99 children from 73 migrant families, 17% were zero dose, 12% were totally unimmunized, and 41% were partially immunized. Major challenges identified are related to unmapped population, transportation inadequacy, inadequate human resource and infrastructure, resistant families, limited accessibility, and inadequate knowledge, and also fear of side effects or adverse event. So as to improve the immunization coverage in GIDC areas, strengthening of existing system is necessary, along with improvement in primary health care, which is needed in collaboration with health department as well as local stakeholders from industrial area. So our future direction would be to carry out population and area mapping with actual headcount survey, involve stakeholders to develop a migration tracking system. More health worker staff should be recruited according to the population norm. Industrial area-specific outreach sites should be developed, and there is a need to start UWIN early. Revision of microplan and arrangement of mobile sessions along with some evening sessions. Provision of mobility support and arrangement of mobile unit, and interpersonal communication with families, IEC activity, SBCC model to engage community leaders and religious leaders. We thank everyone for supporting this study. Special thanks to UNICEF for funding. Thank you.
Do you have any references for this study?
Yes, sir. But we have, due to some emergency situation, we have not included everything in the...
No problem, no problem.
But at the time of final write-up, we have included everything. These are some of the references which are also used for calculation of sample size, and data from government also is included.
Sure, sure. Thank you. So it's open for discussion. Learned judges, would you like to ask some questions?
Thank you for explaining what you did.
Thank you, sir.
Maybe it would be helpful for us to understand that when you converted some of this into the recommendations, we saw a long list of recommendations. How is it different when you frame something for a research study for something that you do actually for a field level program?
Okay.
Do you think all your recommendations here are based upon the data that you've collected?
Yes, sir. These are some of the recommendations that we have suggested. Also, we have tried in pilot basis because we have carried out a meeting along with the local stakeholders, industrial association, industrial head, all the workers or the contractors, they are residing in this industrial area. And we have talked with them, we have talked with the healthcare workers also, and according to their suggestion, we have included recommendations. Also, some of the suggestions we have carried out actually in the pilot phases. For example, this IEC or interpersonal communication, we have carried out with the families that we have interviewed. And when we have done some more discussion with them, they are ready to vaccinate their children, and immediately was there, they have vaccinated their children.
Yes.
So this was actually done at the time of field visit.
One clarification, I was hearing intently while you were presenting. You said something to the lines of only ASHA and no male health worker.
Yes, sir.
How is it relevant and what's the importance here for your intervention?
Okay. Sir, this industrial area are largely divided into two areas. One is pure residential area, and second is industrial area with slums or the pockets, where also migrant resides between 5 to 6 some industries. So whenever these ASHA workers are traveling into their area, these slum or pockets are very far away, and it also poses issue with the security. And currently these ASHA workers are given population, their target is 5,000 or 6,000 per ASHA, which is very much higher as compared to the current population norm. So this poses security challenges. They have to travel for long distance, and male worker is also needed to accompany them, as said by them, that if male worker is provided with us, then it is easier for us to travel into this area. Thank you, sir.
Any question from the audience? So, thank you, Dr. Niyati, for your presentation.
Thank you very much.
Now, the last presentation for this session is from Dr. Shaili Surti. Topic is about sickle cell disease. The details are not provided over here. You are from GMCS? You are from which institute? Okay, do it.
So I am Dr. Shaili Surti. I am currently working as an assistant professor with the Parul Institute of Medical Science and Research. Okay. So I'll be presenting about the study. It's titled Development of the Comprehensive Care Model for Sickle Cell Disease in Chota Udeipur district of Gujarat, an interventional study. India has reported the highest hemoglobin S allele frequency in South Asia. And in Gujarat, the prevalence is estimated at 70,000 for the disease patients and 9 lakh for the trait patients. Despite of these numbers, up till recently, there has been absence of nationwide public health program for screening, prevention, and management of the sickle cell disease. So keeping this in mind, the objectives of this study was to develop an effective intervention model to strengthen the healthcare system to diagnose and manage the sickle cell disease patients, especially in the tribal areas, and to improve the knowledge of the community for better utilization of the healthcare system for prevention and management of the disease. The study was designed multi-centric, quasi-experimental, conducted from 2019 to 2022. It was funded by the ICMR as a part of National Task Force project and conducted in 3 phases. Formative phase, which was for the 1 year, intervention phase again for the 1 year, and evaluation phase for the 9 months. For today's presentation, I'll be only talking about one of the sites, that is Chota Udeipur district. 4 PHCs were selected, 2 for intervention and 2 for control arm. Target population were general community and the healthcare workers. In the formative phase, knowledge assessment and health system capacity readiness was assessed through quantitative surveys, focus group discussions, key informant interviews with the community, in-depth interviews with the healthcare providers, and observations of the subcenters and PHCs. In the intervention, it began with the advocacy with the state health system and the district health officials for smooth intervention. IEC was done through posters, standee, and pamphlet throughout the year. Training of the healthcare workers was done for the screening and diagnosis, and kits were also provided as a part of the intervention to them. Screening of the sickle cell disease in community was done through symptomatic checklist given to the ASHA, prepared by the sickle cell disease experts throughout the country. Some were called for this. They prepared a checklist. ASHA workers were to use it for screening. Those who tested positive for any of the symptom in the checklist were further referred for solubility test at the sub-centers, for which A&M were trained to do it. And those who tested positive for the solubility, they were further referred to the PHC to be tested through electrophoresis by the laboratory technician. The evaluation phase included impact assessment, which was again very similar to the formative. We did the quantitative surveys, focus group discussions, and key informant interviews with the community, and in-depth interviews with the healthcare providers. The key findings of this at the community level were as follows. So despite 75.3% of respondents having heard of sickle cell disease before, especially in our state because we have some state project going on, they had heard of the disease, only 20% could perceive the correct cause. It was improved to 62% post-intervention. Knowledge of the correct diagnostic method in 72% of the respondents during formative phase increased to 86.8. Extreme pain anywhere in the body correctly perceived as major symptom by 45.2% at the baseline went up to 83% at the end line, all in the intervention arm. And 77% respondents reported modern medicine as a treatment for SCD at the end line in comparison to 48.1% at the baseline. So from cause, diagnosis to symptoms and treatment, knowledge had improved in all the aspects. At the health system level, most of the healthcare providers were aware of the correct cause, etiology, and symptoms post-intervention. They successfully performed the solubility test and electrophoresis test after training, and they found it useful to not rely on higher center for confirmatory diagnosis. Medical officers had inadequate knowledge and hesitancy about prescribing hydroxyurea before because of certain side effects, but training as a part of intervention helped them to prescribe it confidently. These are the number of patients who underwent screening and diagnostic test under the intervention. Asha had screened through the checklist all the possible people in their villages under 2 PHCs. Those who tested positive in that checklist were 1,526. In the solubility testing, 752 were found positive, of which 670 underwent electrophoresis. 396 were the trade patients and 52 were the disease patients who all were started on the treatment. Study findings revealed that screening and management of the disease can be effectively implemented at the PHCs by the health workers themselves, facilitating greater acceptance and sustainability in the community. Culturally adapted health education interventions can improve the variables of knowledge related to the sickle cell disease. Evidence generated by this study can provide assistance to formulate policies for effective implementation of the comprehensive program for sickle cell disease in the rural public health system, especially in the tribal districts, to attain desired outcomes. Thank you for listening.
Now, do you have some references also?
So these are the publications we've done so far.
Out of this? Okay, fine.
Out of this.
Now, one question which I would like to ask. It was a multi-centric study.
Yes, sir.
So, can you elaborate on your role, what role you had in the designing the protocol, study design?
Yes, sir. So they, first of all, called all the investigators from all the sites. And there was a principal investigator from the ICMR division also involved. And he kind of chaired the session between all the investigators and came up with a common protocol. We all had submitted individual protocols which were then kind of united to come unanimous. Yeah.
So I refer to the judges to put up the questions.
Nothing specific, but we would like to understand a little bit more from you.
Sure,
You said
sir.
that the primary principal investigator was from the ICMR.
Yes, sir.
And you said you're presenting the work only for one district.
Okay.
So how many other districts were there that were under you as a site? And is this reflective of the situation that you've seen in other districts as well?
Yes, sir. I'll answer the first question about the other districts. Sir, there was one district from Odisha, one from Andhra Pradesh, one Andhra Pradesh, and Assam, and us. And sir, the conclusion, I'll only talk about the conclusion. It was the same, sir. Every site had successfully implemented this. And even we have another project going on with the same patients now, and still with a gap of 2 years in between, we started on the same cohort, we started another project. They're still on treatment. So the intervention is sustainable even right now in all the states.
Right. Could you elaborate a little bit more about how this intervention package was designed? You explained to us that it went through 3 phases. We understand that part of it. But how was the co-creation of the intervention package?
Okay, so what was the investigator's role in how to design it?
Yes. What was the investigator's role, and what was the role of the sites and for the individual teams within the institution?
So what we did was, before the formative phase only, we had come up with certain ideas about the intervention, and we decided upon it after the formative phase analysis, the data. It was done with the inputs from all the investigators. I am the only one from the public health. There are other from the biotechnology, microbiology, anatomy, that is genetic counselor, and the one from the ICMR was system health research expert and implementation research expert. So all of these experts together designed the interventions. So they were all from different fields, not all from PSMs.
Dr. Ramesh, your question? Anybody from the audience?
Thank you.
Dr. Shaili, question. So yeah, electrophoresis diagnosis for sickle cell is really tough for the lab technician. You go with there is a tremendous training. Still, there are some false negative and false positive results. Is there any cross-checking with HPLC2 variants machine?
So not as a part of our project.
Okay.
But we had done some, because we don't even have a prevalence data for sickle cell disease. Sorry. We don't even have that. So we had done screening of 200 children before we began the study to know the prevalence, because Gujarat had some prevalence data, not the other. In that, we had done confirmatory by the HPLC. But the purpose of this project is to strengthen the rural health system. Providing HPLC to these places would be very much costly. And this is an option. According to the biotechnology, people was HPLC. So.
Dr. Shaili for the presentation. The session is coming to an end. I thank participants, audience, and my colleagues for their patience doing their job. I hand over mic to the organizers.
Thank you so much, sir. We wait for our judges to prepare the tallies and the results of the function. I now request our chair, Professor Pradeep Kumar, to kindly felicitate our judges, Dr. Himang and Dr. Animesh Jain. I now request Dr. Anish Sinha to kindly felicitate our chair for today. Thank you so much. We take a really short break as we move on to our next section, which is the valedictory ceremony. Please be seated for the valedictory function. We are pleased to announce the valedictory ceremony of the IAPSM National and State Body 2024, marking the culmination of an inspiring journey of knowledge, sharing discussions, and collaborating in the field of community medicine. I invite all the delegates, attendees, and speakers to join us as we conclude this enriching experience with an eye towards future collaborations and continued advancement in public health. May I now request Dr. Deepak Saxena, Dr. Anna Kulkarni, Dr. Purushottam Gi, Dr. Bhavesh Modi, Dr. Atul Trivedi, and Dr. Anish Sinha to kindly join us on the stage. I invite Dr. Atul Trivedi, Secretary Gujarat State, to say a few words.
Good afternoon. I know the important time, but anyway, we are just now nearing to completion of the gist of the academic feast, and of course, congratulations to organizers for conducting full academic gathering and interactive sessions, and invited high-end qualified and speakers, which really makes our time it's definitely make our time very very encouraging. Now in that end of the session, I would like to announce just about the presidential award, right? So in last year we have started the formality decided the presidential award. This award, current year award, goes to Dr. Devi Gohil. So Presidential Appreciation Award. Yeah, I invite Dr. Vaidehi to come out dais. Dr. Vaidehi, she is from the MK Shah College. She has passed out from the Rajkot PDU Rajkot, and right from beginning she is very active subject. Also she is very keen and always forward for the academic activities as our activity. Dr. Vaidehi, congratulations, and we same kind of the involvement in future also. Thank you. So it's now time for the announcement of our winners of the sessions, and I invite our organizer team to announce it. And till thanks to all. Thank you.
We now announce the winner of the Shri H.M. Patel Oral Presentation Award. It goes to Dr. Shaili Surti. Please give her a warm round of applause. Congratulations. A big round of applause. This is such an honor. We would give of participation to all our participants for the H.M. Patel oral presentation. I request Dr. Aruma to please come on stage. I request Dr. join. Dr. Niyati Kumari Parmar, please. Dr. Rujit Narwal, please. Dr. Raj. Thank you once again to all the participants. We now announce of the comes the oral presentations and communicable diseases. The first prize is Dr. Meet Chauhan. Dr. Meet Chauhan. Second is Dr. Bhavesh Bhai. Dr. Bhavesh Bhai. Like to announce the prize are courtesy Dr. Purushottam Giri, and the runners-up will receive vouchers from Crossword IIG supported by Heart Foundation and Research Institute. Our winners for the non-communicable diseases, the first prize goes to Keith. Second prize goes to Dr. Birva Vyas. A big round of applause, please. The RMNCHA Award, the first prize, Dr. Mital Bharat, and the second prize, Dr. Pratish Chaudhary. Now announce the Resilient Healthcare Systems. The first prize winner is Dr. Shailesh Prajapati, and the second is Dr. Priyanka Shah. She's Pritisha Chaudhary. Dr. Shailesh Prajapati, are you there with us? Dr. Priyanka Shah? Announcing the winners of the poster presentation. Communicable and non-communicable diseases, first prize, Dr. Priya Patel. Second prize, Dr. Riya Panchal. RMNCHA, first prize winner, Dr. Yogesh. And second prize, we have a tie, Dr. Dharmik Chadha and Dr. Paramkus Swami. Health system and others. First prize, Dr. Nirmika Patel, GMS. Second prize, Dr. Anjun Barod, BJ Medical College. Yogesh from MP Shah Medical College, do we have you with us? He's not here. Okay, we have someone, Dr. Yogesh Patel's friend. Dr. Anjun Barot, BJ Medical College. Do we have Dr. Anjun Barot with us? If there's anyone else who can represent him from BJ Medical College? Nobody? Okay. Next, we have Dr. Mithil Barat from NHL Municipal Medical College, Ahmedabad. A big round of applause for all. We now move on to the IAPSM GC quiz winners. Proud to announce Dr. Meghal Shah and Dr. Akanksha from IIPHG as the winners. Our first runner-up, Dr. Parth Munya and Dr. Shubham Patel from Nagar. A huge round of applause. Our runners up, please. Our first runners up, Dr. Parth Munya and Dr. Shubham Patel. We would also like to give a certificate of participation for Dr. Ankit Thomas and Dr. Shubhashri Panda from IIHG. And Dr. Janvi Prajapati and Dr. Karamata from GM Bhavnagar. Please join us here on stage. Quiz, a certificate of appreciation for Dr. Vedi Govil, Dr. Avik Rana, Dr. Neha Bhatt, Dr. Bhavna Pawar, and Dr. Kalpana. Dr. Kalpita. We are also proud to announce the Young Scientist Award, Dr. Trusha Kansagra, here on stage. Young Scientist Award, Dr. Trusha. Do we have you here? Is there anyone for her? Rupa. Round of applause to all our winners. Each participant is actually a winner. To Charlotte Chaudhary, thanks.
Hello everyone. So, it is often said that time is relative. In a good company, it goes by very quickly. So it seems now, as the 31st IPSM Gujarat chapter, 13th IPHA Gujarat State Branch Conference comes towards its conclusion. I am extremely grateful to the organizing committee for giving me this opportunity to deliver the vote of thanks on behalf of the committee. It is truly a privilege. First of all, I would thank the stalwarts of PSM fraternity for gracing this occasion with their presence. It is truly their blessings and guiding light which shines through us. I would like to thank our esteemed guests and dignitaries for their invaluable presence which brought charm to this event. I would like to thank Dr. Anarao Kulkarni sir, President IAPSM, and Dr. Purushottam Giri sir, Secretary IAPSM, for their constant presence and support. Special thanks to all esteemed chairs and judges for shelling out their valuable time in imparting their wisdom and advancing the work of academia. I would also like to extend my deepest gratitude to all esteemed speakers, many who traveled long distance, whose contribution were extremely enriching and inspiring for the attendees of the conference. I am very thankful to all delegates for their active participation in the conference and the pre-conference workshops and making it very vibrant. I would like to thank SHSRC Gujarat for the support which led to the tremendous success of pre-conference workshop. Special thanks to all pre-conference technical supporters for delivering high-quality sessions. I would like to thank Health and Family Welfare Department Gujarat and National Health Mission for their kind support. A special thanks to our principal sponsor, UNDP India, co-sponsors UNICEF Gujarat, Naira Energy, India Primary Healthcare Initiative, Astral Foundation, Heart Foundation and Research Institute, Cohort, and Nidhi TBI. With their generous support, we were able to transform our plans into reality and make the event as comfortable and enriching as possible. I would like to thank the entire IAPSM Gujarat chapter committee, especially Dr. Bhavesh Modi sir and Atul Trivedi sir, for their constant support and guidance at each and every step of planning and execution. They would always quickly respond to our calls and solve our queries. Thank you, sirs. Huge thanks to the entire organizing committee for tirelessly working and for making this event successful. In this entire endeavor, a big round of applause, they deserve it. In this entire endeavor, a special mention I must make is of the organizing chairman and our director, sir, Dr. Deepak Saxena, and the organizing secretary and our registrar, Dr. Anish Sinha, sir. Where our inexperienced minds would end its thinking, they would step in and ask us, ye kiya kya, ye ho gaya kya, ye dekh liya kya. And that would exactly be what we would have missed. They are generous enough to give the team the entire credit and take all the missed credits, if any, due to our mistake upon them, which shows what great leaders they truly are. Very special thanks to Dr. Medha Wadhwa and Dr. Smita Rani for being the MC of the event. The way they anchored the entire event, which was not an easy task, was truly commendable. I would like to thank all our faculties, research staff, admin team, and student volunteers for being on toes constantly and making this event successful. Your contribution to this event is truly cherished. A special mention I must make is of the most active role played by Mr. Devang Raval, our conference coordinator, who was on his toes since we started the planning of this event. He was with us, and anywhere anybody is stuck, the standard response would be Devang ne khabar hai. But unfortunately, he's not with us today due to the demise of his father. Special thanks to all support and house staff for taking care of all guests with a smile on their face. The list of people I want to thank is very long, and believe me, I really want to take each and every individual's name, but due to paucity of time, to restrain myself. In case I have missed anyone, please consider my apology for the same. We have meticulously ensured to take care of each and every guest, but in case if there was any lacunae or mistake on our, I seek heartfelt apologies for that. So wishing all and healthy life until we meet next time. Ending my vote of thanks with the Puna Om Purnamidam Purnamidam Purnat Purnamudachyate Purnasya Purnamadaya Purnavasishyate. Om Tat Sat. Long live IPSM. Jai Hind, Jai Bharat.
Thank you. It's a big applause for this organizing committee, especially Dr. Professor Deep Saxena, Dr. Anish Sinha, President Dr. Modi, Dr. Atul Trivedi, and whole Gujarat. I recite only 2 lines. आए हैं हम दूर से, आए हैं हम दूर से दूर तक जाएंगे, आए हैं हम दूर से दूर तक आएंगे, लेकिन देर तक हम आप सबको नहीं भूल पाएंगे, लेकिन देर तक हम आप सबको नहीं भूल पाएंगे। राह के सारे कांटे, राह के सारे कांटे हम साथ लेकर जाएंगे, राह के सारे कांटे हम साथ लेकर जाएंगे, और फूल आप सबके लिए छोड़ जाएंगे, और फूल आप सबके लिए छोड़ जाएंगे। जय हिंद, जय भारत। लॉन्ग लाइव IPSM, लॉन्ग लाइव IPHA।
I would now request for everyone to join us for lunch after the national anthem. Ladies and gentlemen, please rise for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Sir, all those who have helped us in this organization, our student volunteers, research staff, please come on the stage for a photograph. All student volunteers are requested on the stage, research team, admin team, faculties who have contributed immensely in this organization, please come forward to the stage.